Good morning, everybody. My name is Marie Murphy, and I'm Dean of Postgraduate Research at Ulster University, and it's my great pleasure to welcome you to this morning's webinar, or today's webinar, COVID-19 Moving On. I had intended to be welcoming you all this morning to our lovely Harbour Commissioner's office in Belfast, and when we started planning this, we were having all sorts of debates about what we would serve for refreshments and where people would park and how we would get access and what would be the best day of the week. Little did we know that COVID had very different plans for us. So I hope you are sitting or standing comfortably, that you have found your own coffee, tea and refreshments, and I'm really sorry not to be able to host you this morning. But I'm delighted to be able to introduce this webinar. It's been in the planning for over a year, and essentially it has two purposes. The first purpose, and we are very grateful to the physiotherapy group in the Belfast Trust, in particular Lou Sayers, Deirdre Winters, Kelly Carolyn and Julie Monaghan, who are with us today, because really this is their physical activity study day. And I was privileged in 2017 to be a speaker when it was in Riddell Hall, and it was an excellent event, and I'm sure many of you were there. So that's the main purpose of that, is so that the physio and the allied health professions community can keep abreast of current research in the area of physical activity and sedentary behaviour, so that they can connect with other colleagues, specifically to bring clinicians, academics and practitioners together across the public health, physical activity spectrum. And I think from looking at the attendance list, even though we've managed to do that today. We've managed to bring a great mix of allied health professionals, public health, physical activity, and some academics. Today's session is divided into six sessions. And we know that sitting for long periods is not good for us. And we also know that concentration spans, when we're looking at our screens more and more, are challenged. So what we've done is we have today's webinar broken into 6 separate sessions, and you'll be pleased to hear that there are short breaks where we're hoping you're going to get up, get moving, get active, as well as perhaps pick up some refreshments. But also the sessions become progressively shorter as the day goes on, bearing in mind how challenging it is to concentrate when looking at a screen all day. So we're starting with a session at 1 hour, 10 minutes, and by the end of the day, those sessions get shorter. So hopefully, if you're with us for the day, it won't feel too monotonous. You'll get a chance to move around. A little bit of housekeeping before I start. Our purpose today is not only to have the physical activity and AHP community come together, but also to share the findings of a European project funded by Erasmus Plus, which Ulster University are pleased to be involved in. And we'll be hearing later from colleagues from the University of Bologna who lead that project, and colleagues from Erlangen in Germany who are also collaborators on that project. And the aim of that project is to look at the evidence base and to test interventions for physical activity in people with osteoporosis. So hopefully it will be of interest to this audience, and that's why we thought it would be a great partnership to work with the physical activity group within the Belfast Trust. A little bit of housekeeping before we start. The webinar is now being recorded, and a recording will be available afterwards, and we'll send a link to all participants. So if you miss any bit of it, then you will be able to view it later. And I think we'll be able to segment it, so you'll be able to select which speaker you want to listen to. We have muted all of your microphones, and we will keep them muted for the duration of the seminar. But if you want to ask a question, please use the chat function. For those of you who are new to Zoom, then down the bottom you will see a little chat box, and if you put your chat in there, then my colleagues Kyle and Angela and colleagues from the Trust, Lou, Julie, Deirdre and Kelly, will keep an eye on them, and we'll make sure that they either get answered or get raised with the speaker. As you all know probably better than I do, today is Allied Health Professionals Day, and so we're asking you, if you are tweeting today, and we encourage you to do so, can you use 2 hashtags, moving on, and then AHP's Day 2020. And finally, in terms of housekeeping, with a little bit of experimentation, I was a Zoom virgin until relatively recently, and I'm learning as we go, even this morning. And probably the best way to see both the slides and the one person who is speaking is if you go to the top right-hand corner and press or select speaker view, and that will allow you to see just the person who is speaking and their slides. So that might help for your viewing pleasure. It is now my very great pleasure to hand over to the Chief Allied Health Profession Officer for Northern Ireland, Jenny Keane. This is a busy day, needless to say, for Jenny, because it is Allied Health Professionals Day. Jenny was appointed as the Chief Allied Health Professions Officer in 2019. She's responsible for advising Northern Ireland Government on all matters relating to AHPs, and she provides professional advice and support to the Minister. This is a busy day for those of you who are not in Northern Ireland, a busy day not just because of AHPs, but because our health department and our health minister are obviously ready to make some announcements. So I know that Jenny has a fairly tight timeline and needs to leave us quickly. So without further ado, I'll hand over to Jenny to welcome us and give us an introduction. Jenny, over to you.
Good morning, colleagues. Bear with me as I share my screen. And hopefully this works for me. So good morning, and thank you for that lovely introduction, Marie. Really delighted to see so many of you here this morning and so many familiar faces as well. And a particular thank you to Deirdre Winters for inviting me. Really pleased to be able to join with you this morning. I think this morning's topic, as part of my welcome, I have to say that it's very relevant, and it's very relevant within government conversations and policy direction, because the most pertinent objective within Northern Ireland government at the moment, while we're in a new period, it is still the objectives within Programme for Government. Our objectives within Programme for Government are to try and ensure the health and well-being of the entire population of Northern Ireland. But importantly, it's also one of the key drivers is to reduce the gap between those that have good health and those that don't have good health. And as we move on from COVID-19, or we move on to try and live with COVID-19, probably the most stark piece of evidence that's coming through to us is the differential between those who, before we moved into lockdown, had disparity between who had good health and who didn't have good health. That gap is now widening. The gap is widening in the context of social mobility, whether it's digital health, access to education. And of course, this morning, you're talking about physical activity. And I do wonder whether there is also a similar gap with those individuals who have had good habits of physical activity embedded into their lifestyle pre-COVID, and those that didn't have, and whether that gap will grow wider as a consequence of lockdown and as a consequence of the other changes to our behaviour and to our lifestyle as we move through. The guiding, I suppose our guiding document throughout within the Department of Health is health and wellbeing, and our health and wellbeing policy is there to provide us with a roadmap for the transformation of health and social care services. We always reflect back to it. It's referenced strongly within Programme for Government, but within that context, we also need to take account of some of the bigger public health messages that are global. So, I mean, the World Health Organization describes physical inactivity as a global public health pandemic, and I think it is really important. And I know all of you are far better versed than me in the evidence of the impact of physical activity and how it's correlated against a bigger global health problem than, tobacco and alcohol at this point. And in the context of financial impact, piece of information that I've taken from BMJ was the economic burden of physical inactivity. And again, I think that will only increase as a consequence of lockdown. But for me, it's not the increase, it's actually the gap between those that are physically active and those that aren't. That is most concerning. And I think it's most concerning for anybody that's involved in policy and in trying to improve overall health and well-being for our population. You'll not be surprised if I focus on the fact that, yes, today is National AHP Day. It's a celebration of the collective effort and the collective family of the allied health professions across not just the United Kingdom, but internationally. It was great this morning to wake up to early messages from Australia and New Zealand, where they kicked off, obviously, before we did. But we are an important, we're important in that we're in the fight against that inequity between those that have good health and well-being habits and those that don't. As the second largest workforce, we are ideally placed, and I know a lot of you do, to make every contact count, to embed physical activity into everyday behaviour. As the second largest workforce, it is part of what we do. I don't think all of us fully appreciate the impact that we can have on that. And I have pulled up a slide for the We Active Challenge. The allied health professions always engage really actively. And this is a challenge that's held yearly about trying to incorporate daily activity into every day. So it's not about the going out to do exercise or going for planned physical activity. It is including activity in your daily life. I do believe that over the last couple of years, the contribution from the allied health community in Northern Ireland has massively increased. One of our participants this morning, I think, had single-handedly probably accounts for a good 20 to 30% of that. So that's Elaine McConnell. I can see she's on. She's certainly one of our strongest advocates, wider across all of the allied health professions, constantly keeps us reminded of the importance of that every contact counts, and embed that prevention across all of our work. Like I said, I think it's important that as a community we routinely include the every contact count into every single contact. And while our physiotherapists are well aware of that contact and the wider community can understand how they do that, I've given a few other examples up here that I think need to be, that are good to consider. Obviously, there's the physiotherapists teaching parents how to engage their young children in active play. Again, I think that's particularly important in that social divide. The prosthetist working with a child following an amputation to ensure that they're confident to participate in physical education at school. Perhaps not a group you would think of, but therapeutic radiographers explaining how increased physical activity will help them to manage the treatment side effects of radiotherapy and also to improve the outcomes following a course of treatment for cancer. The occupational therapists using physical activity as a way to manage anxiety with a young gentleman perhaps following a head injury. Our paramedics discussing physical activity as a means of promoting independence and reducing the risk of fall with older people in their own homes. And then our podiatrists promoting physical activity to older people with a leg ulcer as a way of promoting healing and improving cardiovascular health. I've used these examples as a means of describing how physical activity can be incorporated as part of everyday activity and everyday intervention. I'm briefly going to draw your attention to UK AHP public health framework. And I think it's important. It's a useful document. It's useful because it describes the vision and the the intention of all the 4 countries in how allied health professions can improve the public health message, and physical activity features strongly within that. And one of the things which I think is increasingly as a consequence of COVID being brought through from this framework is the need for strong public health messages, particularly again relation to physical activity and hydration, is to the workplace, to occupations. So as a consequence of COVID, the public health messaging and the advice to workforces, including our own workforce, from allied health professions and others, to actually incorporate physical activity as part of our occupation to keep ourselves well while we're at work, whether that's at home or directly on the front line. I can't finish today without acknowledging that physical health and well-being, for me certainly, that it's not, physical activity is not about just physical well-being. It's intrinsically linked to mental well-being. So this is just a piece that I've pulled up, that the mind and body are inseparable. Mental and physical health conditions are often connected. When mental health and physical health problems are combined, people are less able to manage their conditions properly and their health outcomes become worse. And finally, I have again included the slide which sings to me about one of the key benefits of physical activity, and it's that ability to balance our day, to balance our mind, to balance how we address our approach to daily activity. And I think that physical activity is the piece which can be incorporated across career, business, work, life, health, family. And it's one of those things that, because everybody understands what physical activity is, it can sometimes not then be incorporated as one of the really big enablers. So I'd like to wish you all the best for today. I really wish, I do intend to listen back to quite a number of the speakers, if not all of them, because I think the one thing that struck me as I looked through the programme was the amount of absolute translation of research into practice and the amount of very pragmatic interventions and proposals that are throughout the timetable that can actually be incorporated into the daily, daily and right away. So thank you very much, Marie.
We'd just like to say a huge thanks to Jenny Keane. We know that you have a number of other engagements to attend today as part of our International AHP Day, and we are so grateful that you took the time to open up our webinar. As physios, we really recognise the opportunity that we have in disseminating the important information of the public health messages relating to physical activity and reducing patients and the public sedentary behaviour. It's really important, and we recognise that we deliver a message that is current and relevant, and we really are looking forward to welcoming all of the expert panel that have come today. I'd really like to thank our colleagues at the University of Ulster, Marie, Kyle and Angela, for the opportunity today to co-host with them and in cooperation with the ACTLIFE project. I would also like to thank my own colleagues, particularly Lou Sayers, Julie Monaghan and Deirdre Winters, who have put a lot of work into organising this wonderful day for us all. So thanks again, Jenny.
Thank you.
Okay.
Enjoy your day.
Thank you. Next, I'd like to introduce Dr. Jenny Jones. Jenny has more than 20 years clinical experience in cardiovascular disease prevention and rehabilitation. She's worked at Imperial College London, developing and delivering a range of postgraduate programs in the area. She is now the Director of Training and Education for the National Institute for Prevention and cardiovascular health, and she's a senior lecturer at NUI Galway, where she directs a portfolio of postgraduate programs in the speciality of preventative medicines and cardiovascular health. She has served as president to both the British Association for Cardiovascular Prevention and Rehabilitation, as well as the Association of Chartered Physiotherapists in Cardiac Rehabilitation. Her research interests include non-communicable disease prevention and control, and she has a special interest in cardiovascular prevention and rehabilitation, lifestyle medicine, health behavior change, and health promotion approaches to cardiovascular health and diabetes prevention. Her talk today, it will consider interventions used in cardiovascular prevention and rehabilitation, and we're really looking forward to hearing it, Jenny. Thank you.
Thank you. Thank you very much. And thank you to the organisers for this fantastic opportunity to join you today. So I'm going to focus on sort of cardiovascular prevention and rehabilitation, particularly around, lifestyle interventions, and obviously physical activity and exercise is cornerstone within that context. Pictured here is the Cree Heart and Stroke Centre in Galway, where I'm affiliated, and that's where our NIPC is based as well, across the way from the university. And then I also work at Brunel University running a chronic conditions group, so I still deliver clinically with the students, and I'm going to talk to you about that today as well. So in terms of today, I just want to give a little bit of brief context around prevention in cardiovascular disease, a little bit of time around just reminding us of the cardioprotective nature of physical activity, reducing sedentary time, and how that has huge implications for long-term conditions, and then share with you some practical examples of initiatives, and I suppose share with you my, strong beliefs around, what works and what's really important for us to think about as allied health professionals, as healthcare providers, and training the future generation in their delivery. So in terms of a little bit of context, many of you, I'm sure, will be very aware that cardiovascular disease remains the world's biggest killer. Around 18 million people each year across the world. And in a nutshell, 1 in 3 individuals across the world will die from cardiovascular disease, and many of them prematurely. So it's a very common condition, and it's not just death. Many, many people survive their events. And so we have a growing population of people living with non-communicable conditions, including very commonly cardiovascular disease. Now in the UK and in Ireland, cancer has slightly overtaken cardiovascular disease, but they're pretty close. And they share the same risk factors largely in terms of physical activity, and exercise obviously applies to both. And I'm a big believer, that's why I run a chronic conditions group rather than a disease-specific group, because I think that physical activity and exercise across all of these conditions is really important. And whilst a person might present having had a cardiac event, you are protecting, or you're giving interventions that protect much more broadly than that in terms of an array of chronic conditions. So what works? So the first thing I want to say is what works? Well, cardiac rehab or cardiovascular prevention and rehabilitation work. So in our long-term plan, and obviously that's country specific, but the paramounts are exactly the same. The applicability is very relevant, that currently we have 50% of people taking up a cardiac rehab program across the countries that are measured. So Scotland isn't part of that audit, but if you take the other countries and you look at the average, it's 50%. And this is a class 1A evidence service. So we know that it's highly, highly effective, and yet 50% of people don't avail. So one of the key milestones is to up the uptake to 85%, which would actually translate to massive benefits in terms of the healthcare system, as well as obviously on an individual level in terms of quality of life. So how do we do that? So the first thing is that cardiac rehab works, and the glue to cardiac rehab is actually exercise training and physical activity, amongst many other core components. And we have guidance. So those of you who aren't so familiar with the national guidance, these are the sort of 2 top things to have a look at. So we have our BACPR standards and core components, and we have our physiotherapy group has produced some really good guidance around the delivery of the exercise and physical activity interventions in a range of people with cardiovascular disease. I want to point out, I suppose, to home in, that health behaviour change and education are in the heart of the model for cardiac rehabilitation. And I think that's a really important message. I personally, when I trained as a physiotherapist, looking back, whilst I believed I was good at talking to people and motivating them and so on, now that I've actually had formal training in health behaviour change, I realise for many years I've been really bad at it. So I think one of my first sort of passions is around bringing health behaviour change into all the syllabuses of healthcare practitioners so that we can be skilled. Many of us are naturally good at it, but others may be like me and actually benefit from formal training. Now we're in a context of, we know that cardiac rehab works and is highly, highly effective, but we are in a population who are at high risk in the context of coronavirus. And this isn't going to go away anytime soon for those individuals. So we're having to really think innovatively and think about remote approaches, because these individuals, actually that face-to-face interaction is very problematic from a risk point of view. And you can see there from the BHF that about 45% of people who have COVID-19 and die, they have mentioned in their death certificates of circulatory, heart and circulatory disease. So this is a high risk group that we're talking about in terms of physical activity and exercise, and making sure we can provide using innovation. So our British Association for Cardiovascular Prevention and Rehabilitation have produced a number of statements. They're very, very useful. So again, just to give guidance to practitioners and services who are having to really redesign themselves and reconfigure themselves. So I've got a question for you. Is cardiovascular disease preventable? So I'm going to try this, see if it works. Okay, so could you have a go at that poll? It should have come up. How much of cardiovascular disease do you think is preventable? So pop in your answers. I'll just give you a few seconds. You've got 1 of 4 options there. Okay, last couple of seconds. And let's just have a little look. So I'm going to share the results. And you are absolutely right with the majority. So 80% is the correct answer. And in fact, the data would suggest, depending on exactly which aspect of cardiovascular disease we are referring to, that even up to 90% has been modelled to be shown to be avoidable. And I think that's really important in the context of physical activity and exercise, because it's a cornerstone aspect to that prevention. So CVD is largely preventable. And where am I getting this data from? It's not new. We've known for a long time. We've had our case control, a landmark case control study by Salim Yusuf and colleagues has identified that 90% of myocardial infarction can be explained through modifiable risk factors. So this is a landmark trial. And when you then break it down, and you have a look at, or when we talk about these risk factors, Simon Capewell presented, so I've acknowledged his slide here, but I think it is a really important point that diet actually explains 50% or more of coronary heart disease events. So as healthcare practitioners, we need to be confident with what the correct dietary messages are, what the guidelines are. So irrespective of our professional background, we can be promoting something that is hugely protective and possibly underused in many of the clients we work with. You could argue the same for physical activity. So whilst physical activity in the blue on the pie chart here is what the InterHeart study contributed, if you like, to myocardial infarction, I would make exactly the same arguments that hypertension is linked to physical activity, or lipids have links to you know, they can be modified through physical activity behavior, obesity, diabetes, and there are an array of mental health and psychological benefits associated. So physical activity and reducing sedentary behavior, again, like with diet, is cornerstone. So what is it about exercise, and why is exercise the glue of cardiac rehab? Well, I think this slide really nicely explains the anti-atherosclerotic, the antithrombotic, the anti-ischemic, the antiarrhythmic properties, and then the psychological benefits. So you can see why exercise training would be referred to as a medicine. And it is a medicine in terms of the atherosclerotic process and being able to market, if you like. We've got to become really good at marketing exercise because it has so many wonderful benefits for people either at risk of cardiovascular disease or who have been affected. So how well are risk factors being managed in people living with coronary heart disease specifically? So this year, EuroSpire was presented at the European Society of Cardiology, their annual congress, which was digital, like all of our conferences at the moment. And in terms of the findings, I mean, these surveys have been going on since 1990, so they're now on number 5. So this is 2018, essentially, data. And you can see the data for men and women who have had a cardiac event. So these are people with coronary disease, living with coronary disease, and they will have had their event within this sort of year period. So we're looking at a cross-sectional survey. And I think the results are highlighting that we have a really big problem in terms of implementing guidelines. So just to point out a couple of results, but if we look at the medications, for example, most people, the vast majority, are being treated. And yet when you look at how many are actually at blood pressure targets or cholesterol targets, very concerning, and who in terms of diabetes is well managed. And these are very high risk individuals. So we see very negative effects in terms of obesity. I'm going to show you physical activity in a moment. And I think what I would argue here is we come back to that health behavior change and how important it is that people need to look at lifestyle approaches and implement them successfully, which is a challenge because the medicines here don't seem to be actually working on their own. And if you've got negative effects in terms of obesity and so on, just upping medications is not the answer. So I'm going to ask you another question if this works. Go to my polls. Let's relaunch polling. Let's try that. No, I don't want that one. I want the other one. Oh, was that a new? I don't want that question. Polling 2, that's it. Sorry, I think someone was helping me there. And then I stopped them. Okay, so this is the other question I've got for you. So according to EuroSpire 5, so this is the latest survey, and we look specifically at physical activity. What do you think are the results? So who's achieving, and it's just this 150-minute message, that minimum message. Okay, I'll give you a couple more seconds. So have a go. It doesn't matter if you get it right or wrong. It's just to be a bit interactive. Okay, so I'm going to end the polling. And the correct answer is actually 34% B. So not quite as bad as you're all thinking, but it's still pretty bad. Okay, so in terms of, I haven't got a poll for this question, but I just want you to have a little think, and you can pop it into the chat if you like. So in the chat facility, compared to EuroSpire 4, so that would have been in about 2013-ish, 2013-14. What do you think has happened to physical activity levels? Do you think they've stayed the same? Do you think they've got worse? Do you think they've improved a little bit? Or do you think they've improved significantly? So pop it in the chat what you think, just so I can see a couple of ideas before we move on. Okay, right, so the actual answer, if I show you the next slide, a few of you are absolutely right there. So the correct answer is actually that things have actually got worse. So when we look at this, I suppose over time, so a cross-sectional study, and we look at it longitudinally, you can see that in Eurospire 4, that 43.7%, and this is self-reported, but 43.7% of the coronary group were meeting those guidelines. And in Eurospire 5, it's actually gone down to 34%, which is a significant reduction, and a significant reduction in performing regular planned exercise as well. And the intention to increase your activity levels has not changed. That has remained in status quo. So these are people with coronary disease. And I think the answer there is it's highlighting that we have these guidelines and yet we have some way to go in implementing these guidelines. And whilst that's a European survey across 27 countries, including Ireland and the UK, the iAspire survey was carried out last year and has recently shared its results. And we see in an Irish specific context, we see a very similar trend. We see a third of people who are rarely, if doing any regular activity. So the problem is widespread. So I think my first key points in terms of this sort of first section is to just remind ourselves that CVD is largely preventable. Lifestyle is actually cornerstone. It is a centerpiece. And we have some way to go in terms of applying these guidelines successfully into clinical practice. And I personally believe that with lifestyle, we need to make sure we're not using medical models, that we are using more behavioral approaches, and we're using the science of behavior change to more successfully implement and support people to make difficult lifestyle changes. And 50% of people take up cardiac rehab at the moment. We know that that's a 1A class, the evidence is extremely strong. We need to find interventions that also successfully up that uptake. And this is a picture that I'm sure you've seen in other people's presentations. It's a commonly used picture, but I think it sums it up that, lifestyle change is difficult, and where there are medicines available, many people would be more willing to take the tablet than to make that change. And that's why we also, as allied healthcare practitioners, as healthcare providers, we need to think of the big picture as well. And it wasn't until I was more mature in my career that I had a bit of a wake-up call. It was actually Simon Capewell, again, who made that wake-up call for me, which highlighted that I'm running a cardiac rehab program. And if my program is attended by the more educated individual, the person with maybe a higher income, and it's my person who is less educated or in difficulties financially, for example, that isn't attending, I'm actually contributing to that health inequalities gap. I'm actually widening it. And I hadn't really twigged that, and I'm sure many of you have twigged that, but when I did twig that, it was a real take-home message that made me really stop and look at who isn't attending our program, what is it about our program, and making sure that we're just like we're trying to sell a product. If you were trying to sell something in a supermarket, there would be a massive market research to go with it. And that's what we need to do as well, is we need to tap into the people who aren't accessing our services and really design our services with innovation, with their involvement, so that we can actually successfully increase uptake. And then remembering the picture here is a great way of just reminding ourselves that we can be pulling people out at the bottom of the river, resuscitating them if they're drowning, building a hospital there, training people in resuscitation skills. But actually, if up the river, the problem was that there's a bridge with no rail, if we actually address the problem further up. And that's why we as healthcare providers really need to contribute to the more population-based approaches and be advocates for the causes of the causes. So really thinking bigger picture, and not just the person that we are trying to promote a change in terms of benefits. So my key points here is that at the heart of prevention and rehabilitation is intensive risk factor management. And as I've alluded previously, lifestyle is pivotal to that success. We can see through lifestyle that plaques actually regress significantly. So through a strict activity and nutrition program, we've seen in trial after trial after trial, it's not a new finding, that those plaques actually do significantly reduce. But we have to think about the big picture in that context as well, and be aware and very careful that we're not widening health inequalities, that our programs are really designed with that in mind, and that we use social marketing approaches and we use expert approaches to maximize uptake and become advocates for upstream approaches. So my last part is to share some practice with you, and I'm happy if you've got any questions to pop them in the box as we're going along. And if there isn't enough time to answer questions at the end, I'll have a look and type the answers in during the next session. So please do ask if you've got any questions. So this is some of the work that I've been very fortunate to be involved in. And we've done this work in Westminster, London, and we've done this work in Galway. So two very different places geographically and in terms of their population makeup. This program is a nurse-led multidisciplinary service. So it models cardiac rehabilitation. It's comprehensive, it's multifactorial. There's a physical activity specialist as a core member of the team. And what we've seen in two very different settings is that these guidelines can be implemented successfully. Our uptake is 70%. Sometimes it's how we invite people. Why are we inviting them to cardiac rehab? It should just be an obligatory part of your package, your care package after an event or an intervention. So for those of you who are more interested in the sort of details of that intervention and what it looks like, it is widely published and available on various sort of websites that have shared good practice. And the first speaker, Jenny, as well, was sharing with us in a conversation around sort of health economics and prevention. And this is very much our findings as well. So we did a cost-benefit analysis of the program in Galway and the program in Westminster. And despite them having very different populations, we see the same effect, that the prevention works similarly. The prevention model we use works similarly. And it isn't just cost effective, it is cost saving. So we have modeled that, what those cost benefits translate to. And in a nutshell, you know, for every £1 that you invest in the program, you get a £6 return. So there really is no argument to say it's expensive, because actually it saves you money, you could argue, from our findings. So my last share is at Brunel University. We're running the Exercise for My Health program. So this is a chronic conditions group, largely cardiovascular, which you would appreciate given we've already talked about the magnitude of the problem. So we had to turn our program that was face-to-face on the university campus. So I use it as a teaching tool, because I'm a big believer in bring it to life and students get involved and get some experience. So we had to become remote. So the students have been amazing. So we've had students on placements, because we had a big problem with student placements in COVID. So we thought, well, let's be a little bit innovative. Let's create placements and take our program in chronic conditions and make it virtual. It would not have worked as well as it has if the students didn't take up the befriending side. So what they've done is they've phoned somebody, for example, to help get them onto Zoom, because that's been our challenge, is getting these individuals up and running with the technology. They've offered this befriending, they've signed the person into an account, they've created a Zoom account, they've phoned them back, they've got them to log in, they've really supported them in actually getting online. And then they've supported them in where to position the camera so that you can join an exercise class and all of that stuff sort of beforehand and preparing them and how to use the chat and so on. So that's been a really important aspect to the success that we've had. We've been running this now for a few months, and the uptake is great. We have sessions for stroke survivors. We have sort of low functioning sessions, heart failure. We have a session for our more able individuals. The students are running education sessions. They're putting together, for example, you can see here was Annika, one of our students, put together a lovely talk on understanding sedentary behaviour. They're running quizzes with them. They're doing all sorts of fun things. And the uptake and the feedback has been really, really positive. So they're doing, they've recorded exercise sessions for all sorts of abilities, and we've got a private YouTube channel now to try and again improve access, because trying to share it with a OneDrive was problematic for some of the participants. Personalized videos, lots of them have got MSK problems, so they've had the opportunity to deal with their necks and their backs and their other issues. So a really positive experience. So finishing up, aware of the time. So here you may know this data already. I'm very interested in sedentary behaviour in a cardiovascular population, in the knowledge of, for example, this publication that highlights such a negative effect in terms of all-cause mortality when we start to sit more than 7.5 hours, and particularly more than 9.5 hours, but that sort of 7.5 threshold. So we have been working with the University of Leicester with my virtual group, so the virtual participants, and I've got a student who's doing a master's project attached to this. We're posting out active PELs, which measure sedentary time and obviously your physical activity as well. So it's able to differentiate sitting to standing and so on. We're downloading the data, producing the report, and the student is giving the person some feedback and is putting together a package, an individual tailored package that might include, for example, an app to increase your standing, or using a sitting timer, or there's a great website, which, although it's written for work life, is when it's written for sort of like a work setting, the information actually is very applicable. There's lots of goal setting charts, all sorts of tools that are really helpful. Now here's the bit that I was quite shocked about. So we've done previous work with the active PELs through my colleague Charlotte. So she's lent me these devices very kindly. And we've been looking at sort of data in, this is pre-COVID, so this is a high-risk population, meaning they haven't had a coronary event, but they are calculated at high risk because of high blood pressure or high cholesterol or a smoker and so on. And then my other population are people who have just finished cardiac rehab and then they come to me. So it's a follow-on program that I'm running for them. And I think I was quite shocked actually at the results, because if you take the moderate vigorous physical activity, you would hope that that's going to be 30 minutes a day. It would indicate that actually people are probably over-reporting their activity, given that these devices measure very well. And you've just seen the slide about sitting time. So when people have finished cardiac rehab, bearing in mind, these are the ones who want to go on, and they're generally, you know, you could argue they're selective, most likely to be more active. They are sitting on average 10 hours a day, which far exceeds, they're right on that slope. So that's where this student project has come in, and we're putting in an intervention, and we haven't got our results yet. But before the intervention started, so this is my group who are doing virtual at the moment with us, and our baseline is this 8, nearly 9 hours. So we're working on reducing this, seeing if our virtual intervention works. And we're trying to get that moderate vigorous physical activity level up as well in each individual's case through a sort of virtual goal setting, virtual with follow-ups and so on. So it's a very powerful medicine. I don't need to go into that. You could speak for days on the benefits of physical activity and exercise, but there are many barriers. And my last slide is to share with you a slide that Professor John Buckley presented, and I think it just sums up such an important message that sometimes we give advice to people who are in reverse, and we give them the message of this 150 minutes a day, when actually we should just be getting them up and moving. The latest guidelines highlight that there is no minimum threshold for benefit. Just moving a little bit holds a huge benefit. So treating it a little bit like car gears, and whatever gear somebody is in, the goal is actually to get them to the next gear. And perhaps one of the things we might do routinely, which maybe we might avoid doing, is giving these generic messages which don't necessarily assess where somebody's at and sets their goals according to what gear they're in at that time. So in summary, I hope that this virtual approach you've learned something new, or it's inspired you for when we have a coffee break to remind ourselves to move around or even stand up during some of the sessions. But you've seen from the data there are some really big opportunities in implementing better prevention in our practice. So I often teach physiotherapy students and harp on about, if you're an MSK physio, you have so many opportunities to implement prevention. The person comes in with the sore back, you know, are they obese? Are they diabetic? Do they smoke? How active are they? Treat physical activity as a vital sign across all your populations, irregardless of what area you work in. Because the superior allied health professional is the one that is actually preventing the illness. And sometimes we're training our students to deal with sickness and deal with it very, very well. But actually there's masses of opportunities to deal with prevention at the same time. So we have our own prevention conference, which you are very welcome to register for. It's free, so that's a bonus. So it's another free virtual event, great lineup. And my contact details are there if you do want any further information. And we do run a range of courses at each of those places that might be of interest. And thank you for listening.
That is great. Thank you so much, Jenny. There's just a few questions in the chat, which has disappeared. So Lou has asked, what happens when the participants complete your program, and is there any carryover in the community?
So the program, I suppose, because obviously you've seen that I will have lots of hats. So if we talk about the Brunel program, so the long-term conditions program, I actually run that as a program at the university. It doesn't have an end point on purpose because it's offered free of charge to the participants. And the reason it's offered free is students are learning and they're engaging and being part of the students' learning process, which actually, when you read the feedback and the testimonials, they really value being part of the student education process. So there really isn't an end. And what we've ended up doing is working very closely with community groups and different strokes, for example, and the gym at Brunel, and putting together lots of sort of additional sideways, you know, walking, football, all sorts of other interventions, if you like, to give people a choice and to keep them engaged. So I don't know if that answers the question. Basically, there isn't an end per se. There's lots of signposting and additional interventions offered.
Great. Joey has asked, has the cost benefit analysis been helpful for generating additional buy-in for the work, such as funding or policy support?
You would think so, wouldn't you? You would think that you pitch an economic argument, but in all honesty, we face that constant battle for resources in prevention and also in cardiovascular prevention and rehabilitation, or cardiac rehab. If you look to cardiac rehab programs nationally, I would say that many are under-resourced. So it is an area, it's a Cinderella service, and actually it's quite shocking when you see the arguments, and my argument is not new. You know, there's many great economic arguments that many, you know, far superior in knowledge to me have put together, and yet we still have very little investment in prevention.
Great. And then just one final question from Deirdre. Could you share what barriers you identified for people who hadn't previously engaged with your program, especially those that surprised you, and how did you address them?
So is that, I suppose, are we talking about the one, Deirdre might just pop into the chat. Are we talking about the virtual programme barriers, or just overall the experiences of the My Action programme?
I think in general, Jennifer, I suppose, you know, you had talked about how we can contribute to health inequalities. So I suppose I was just interested in your learning.
Yes, yeah. So, and the BHF actually have a really nice resource at the moment about something about tides and forwards, but on the front cover. It really is about thinking innovatively and looking at what the barriers are. So, you know, I've worked in cardiac rehab programs where it's on a particular day at a particular time, and, you know, it's in a particular way. And that's fine for those that can attend and that suits, but actually there's digital forms of it. There's web-based cardiac rehab, there's the heart manual, and I think it comes to that choice. I think the choice is a really, really important thing. I also think, and it's choice of times as well and different approaches. I don't think telemedicine is going to go away now, even if things return to normal. We found another way that gives another choice. I think it's also involving family. So one of the key successes I think we've had with My Action is that the person comes with a partner. They don't have to, of course, you don't force them. But I think that actually makes a very big difference, because you're building a support system into the home as well. And we found that that has been a really important ingredient, actually getting the participant's partner to do the whole program. They have their blood pressure checked, cholesterol, the full lot. They may as well be a patient. And we found that to be a very successful model for sort of long-term effects. So I think those would be my sort of two top things to talk about. And do you want to add to that, Deirdre, in any way?
No, that's great. Thank you.
That's great. Thank you so much, Jenny. I'll hand back now to Marie.
Thank you, Kelly. Thanks for handing back. And thank you, Jenny, for a really fabulous talk. I really enjoyed it. Moving on to the next part of our program, delighted to say that we're on time. We're still doing good for time. And this is the second bit of the content or the purpose of today that I introduced you at the start. And this is the dissemination of the ACTLIFE findings. ACTLIFE is a 3-year project, European-wide, funded by the Erasmus Plus Programme and the Ulster University, and my colleagues Angela and Kyle. We're delighted to be involved in that. It involves partners from Finland, Bulgaria, Northern Ireland, the Republic of Ireland and Germany, but we're led by the lead partner from Italy, from University of Bologna. The purpose of the project is to look at both the development and the dissemination of protocols for the secondary and tertiary prevention of osteoporosis. So we thought that this was an ideal audience to hear a little bit about the project, and we're now at the end of our 3 years. And so to present information on the protocols and some of the work that we've done in the ACTLIFE project, I'm really delighted to be able to welcome the project leaders from Bologna, Laura Braganzoni and Giuseppe Baroni. And I'll hand over to you. I think, Giuseppe, are you going first?
Just a moment and share my screen.
Excellent, thank you.
Okay, did you see the presentation?
Excellent, yes, thank you, Giuseppe.
Okay. Thank you so much. Welcome to everybody. Good morning. This study is a support of the ACTLIFE studies that Mary Murphy kindly present, and is a randomized trial that comparing the gym versus home training exercise for women with postmenopausal osteoporosis. Osteoporosis is a disease of the skeleton characterized by a reduced bone mass, and is associated with decrease of physical and social functional capacity and quality of life. Now, anybody know that there is the efficacy of the physical activity in prevention of bone loss, and everybody know again that the regular participation in physical activity program is really important for all age of group, and in particular in geriatric population. But even if there's this general consensus, the meta-analysis show us that 40 to 65% of participants will drop out from the exercise program. This could be due to different factors, for example, of poor health or poor self-confidence or low motivation, or again, or low perception of exercise enjoyment. And in our previous study, we found that also the adherence is strictly associated to accessibility of the gym. So an individual training could be a valid alternative to the gym group training because it overcomes some problem related to the accessibility of the gym or to respect the timetable. Moreover, there are yet several randomized controlled trials that prove the efficacy of an exercise program in women with osteoporosis. And in the best of our knowledge, there are no studies that compare the effect of individual training versus group training in postmenopausal osteoporosis. So it's clear that each setting could have some advantage or disadvantage. For example, the group training is a greater level of supervision by a trainer. There's a social interaction. At least it could be increase the motivation, but the participant could be respect a timetable, and it could be problematic due to familiarity or work issue. And there's also the distance between the work at home to the gym that could be a problem. So the aim of our study is evaluate the efficacy of the physical activity program when administered in individual home training group or in gym group training group. The study design is a single blind randomized trial with GGT and EHT group. Single blind because the evaluator are not aware to the which exercise group patients are assigned. Woman recruit and perform 12 months ACTLIFE exercise with 2 follow-up at 6 first one and 12 months follow-up at the end of the study. Inclusion criteria is postmenopausal woman with osteoporosis, so the score is less than minus 2.5. Exclusion criteria include the main comorbidity, possibly for geriatric population. Her primary outcome is the quality of life, measured by a short osteoporosis quality of life questionnaire. And the secondary outcome includes a questionnaire, like WODAS, which evaluate the life activity, participations, and domains of cognition. The false efficacy scale, which evaluate the fears fall, and a physical activity scale for elderly, which measure the weekly physical activity. Other secondary outcome include a functional score, so BMI and body composition, 6-minute walking test to measure the gait performance, the Delus proprioceptive system, which is a device who provide to evaluate the balance, static and dynamic balance and proprioception, muscle force measured by an hand grip test, and joint mobility. The adherence was recorded by the trainer in each session in a gym group and by a logbook for people who perform their activity at home. The same ACTLIFE program is administered both in a GGT group and EHT group. Sorry. The program is structured in 2 days a week for around 1 hour a session in both groups. The program is aimed to improve joint mobility, muscle force, static and dynamic balance, motor coordination, and endurance. In particular, along the 12 months, there are 3 phases. In first one, the goal is improve the body awareness and recovery or acquisition the base motor ability. In second phase, the improvement and consolidation of this base motor ability. In third phase, we try to educate all participants to a healthy lifestyle. A single lesson is structured in classical way. So start with a warm-up, balance, strength. There's different impact exercise that is really useful to maintain or improve the bone mass, and finally with cool down. In individual training group, the trainer have a face-to-face lessons with all participants in which explain all the exercise and given an educational material with the picture like you see in this slide, where there's explain how to perform the exercise correctly and the common mistakes. GGT participant could be choose one of two available gym and are supervised by the same trainer along the 12 month. In addition, to reach the 150 minutes by week suggest from World Health Organization, we request to all subjects to perform an additional activity, for example, swimming or walking or cycling, based on their preference. Moreover, every 6-8 weeks around, the trainer upgrade the exercise program in individual training as well to gym group training to improvement based on improvement obtained by every participant. At baseline, the randomization is worse because we have no significant difference between two groups in order of age and also in quality of life. This year, in January, February, we started the 6-month follow-up. We recruit 22 women, but COVID-19 comes in Italy and is have a catastrophic result for our studies, so we didn't complete the 6-month follow-up. So now I show you this preliminary result, just the preliminary result at 6 months. We recruit 11 individual training. The tendency is an improvement of all endpoint. But there's no statistical difference. The same for gym group training, where mostly of endpoints there's a tendency of an improvement without significant difference. Finally, in result, this preliminary result doesn't show a difference between the two groups in any of best perform. So there's in all group, in all participants, a tendency of an improvement of all value. Also in primary outcome, the ECO 16, that slight increase in individual training group and doesn't change in gym group, but there's no significant difference between the group. This could be due because the subject of number analyzed is very low. There's no power analysis that we prevent. Moreover, as we see before, early training period is focused on body perception and body control, and also in exercise movement learning. And finally, the baseline functional level of all subjects, mostly of the subject, is just quite good. So it needs a longer time and a stronger exercise protocol to see more improvement. In conclusion, this first 6-month follow-up in just half of our women show a minor improvement, and for a while that seemed to have significant change. But we hope to perform the 12 months follow-up at the end of the study to all subjects. I would say thank you to Erika Pinelli and Giuseppe Podino, that are the training and all ACTLIFE team. Now I introduce the principal investigator of the study, that she's managed the COVID emergency during the follow-up, and show you the other results. Thank you.
Thank you, Giuseppe.
Good morning, everybody, and thank you for Mary to invite to webinar. And I am very happy to discuss with you and present with you our result concerning the effect of COVID-19 quarantine on ACTLIFE exercise protocol. Well, the adherence to exercise program is a fundamental importance for the program efficacy and is a problematic in all age group, but in particular among older adults. It depends on several factors. Giuseppe before shows a slide that speak about low motivation for health, for self-confidence and other things. But the adherence is the best, the key of predictor for improve back pain and associated with ability to gym and a positive relation with the trainer. This is important, the positive relation with the trainer. So during the trial clinic, COVID pandemic erupted in Italy, but in Europe. And on March 19, 2020, the Italian government imposed a national lockdown. So the lockdown imposed a temporarily closed of no essential activity of business like gym activity, and this causes the interrupt of gym group training and not individual home training. The aim of the study is to investigate where the COVID has different consequences of training practice in the different two groups, individual and G group training. Immediately after the beginning of the lockdown, all participants were contacted by telephone. In individual training, we suggest to continue the weekly training practice as usual, while in GG group training we request to perform physical activity learned during gym at home. For this, educational material as we send by email or by WhatsApp, and for both group training instruction and advice by telephone and video call. After 4 weeks, the beginning of lockdown, we administrate telephone interview. The aim of this interview, is to investigate to adherence the exercise about number of sessions. The participants are not adherents if the number of sessions are less or equal of 75%, and the participants are adherents if the number of the session more 75%. Another aim of interview is to evaluate the different domain like physical state, physical activity, and self-perceived benefits using close question. To evaluate close question, we use a Likert scale. And finally, we understand the exercise benefit of home physical activity perceived by participants by 4 open questions. In our result, at the moment of lockdown, in the study we have recruitment of 52 women. And immediately we have 4 dropout, 1 in individual home group and 3 in gym group training. After 4 weeks of lockdown, the interview was offered to 48 women, but 5 refused interview for family issue, 2 in individual home group and 3 in GG group. In this table, we we can see the characteristic of individual home group and GGT group at the baseline assessment. There is not a different in the same in the both group, so the shows the randomizing is work good. And about adherence, is we amazing, because in an individual own group before the lockdown, adherence 70% of participants. During the lockdown, increase the participant and to arrive to 82%. While in a GG group, the adherence is not good before lockdown, only 50%. After 4-week lockdown, quindi during the lockdown, the adherence increased 70%. This data is very significant. In the table is possible see the question with open answer related the exercise benefit. In the first question is not significant data, but the last question asks why did you exercise at home in lockdown period? And the bit different answer, because in individual home training, the answer is for my well-being. In the GIB group training, only 50% for my well-being. The most percent is 45 in GG group, because inside the study project. Another answer is not important, and this data is statistically significant. Another question, the last open question, is what are the advantages of doing physical activity at home in comparison of doing at the gym? Individual home training have 70% not advanced, but 74% more efficient time management. While gym group training answers that not advanced for 80% and not more evidence time management, only 20%. In a larger table, it's possible to see the result about close answer related domain like physical activity practice, life habit, physical state, and exercise benefit. The domain is not a significant data, but it's important to underline that concerning domain physical activity practice, in both group, the participants are sorry when postponed or stop exercise session. It's important data. This. In conclusion, about discussion, the adherence, individual home training group have been adherence to the program instruction before and during the lockdown period than those of gym group training. In fact, in individual group training before lockdown, the participants perform physical activity at the most convenient time for them. During lockdown, all participants more free time. While in gym group training, before lockdown, perform physical activity imposed by study protocol. We impose the gym as an hour. During lockdown, these participants could choose day and hour. They have more free time, and we don't have travel go home to gym. And it's important to underline that both group is under the direction supervisor or professional trainer is important because the trainer call every week individual home training and gym group training. About adherence, the different as well, because why did we exercise home in lockdown period? Individual group training answer for wellness, for well-being, but GG group training answer to because the participant is included in the study. In a GG group training is not advanced to practice to perform a physical activity at home. But both group to be sorry when postponed or not possible to perform exercise section. And about physical, psychological status, both group not have a different. We have not a low. Have a report is indicate a low impact of lockdown in their psychological well-being. GGT gym group training participants complained a more pain and lack of energize that individual all training participant. Physical activity at home with ongoing support of research staff trainer could have contributed to mitigate the adverse psychological effect of quarantine. Our study are limits. The first limit is not consider the intensity of workload of each session. We don't not is possible report the intensity. Another limit is self-report data to define number and duration of the exercise session may have reliability limitation. In conclusion, exercise protocol have, if based on a supervised gym practice, must consider the possibility to provide more different day and hour and to consider the distance between home and gym. So the ongoing relation and supervisor of trainer by telephone or social media, as well as the support of adequate technology tools may facilitate remote control of training session as suggested in previous study. I thank you the ACTLIFE study, Mary Marfin and University of Ulster and another partner, and thank you the gym, the group of individual and gym group. Thank you everybody.
Thank you very much, Lara and Giuseppe. It seems a very long time since we had a lovely photo in Bologna at the start of the project. It's great to hear some of the results, although obviously I'm sorry to see that the trial had to be suspended like so many others. We have a couple of questions for you. The first one is, did the participants, did they receive any additional support or resources when exercising at home? In particular, I'm thinking the ones whose gym sessions had to stop.
Yes, in a gym by telephone and send the educational material. We produce, we make and a small brochure to show each exercise, and the trainer send this brochure by email or by WhatsApp or by mail.
Okay, excellent. And the other interesting finding from the COVID element of the study, Lara, was that those who were the gym group really adapted, but were only really seemed to be doing the exercise because they were part of the study, where those who had been doing it all along by being in the home group, they were doing it for their well-being. And I wonder whether you could comment on whether that is what you think about that. Is that because exercising at home is more part of normal life and you're doing it for different motives? Have I lost Laura? Or is Giuseppe doing some translating in the background?
Oh, sorry. Sorry. In interview, we report that in individual home training is a physical activity like routine, and they report the same time for each session. But in gym group training, the participant report that make the same number of sessions, but the time is reduced because we don't have supervisor. I think that is because it's not a supervisor from a trainer.
Okay, excellent. Yeah, and in a way that reinforces some of the things that Jenny said just at the beginning, that making physical activity part of normal life as opposed to having to separate it out we might be on a winner if we could encourage that more often, because the gym may be less suitable. Okay, thank you very much, Laura and Giuseppe. I'm delighted to have been able to welcome you virtually to Belfast. I do hope that we'll be able to welcome you physically to Belfast in the future, since you've hosted us in Bologna on several occasions. So thank you very much. Everybody, we are nicely ahead of schedule, and you've been sitting or at least looking at a screen for quite a long time. So we're going to keep with the rejoin time, which is 12:25. My suggestion to you is you don't disconnect from Zoom. You simply, your microphone is muted. You might want to mute your camera unless you want us to watch you eating your lunch, or hide your camera. But we will go on schedule at 12:25, because I know there are some people joining us for that block. Lots more to come after lunch. And we have a further presentation by the ACTLIFE group, the German partners, to finish off with this afternoon. So can I encourage you to get up, get moving, and take a break? But please try to join us again at 12:25. Thank you.
Okay, I'm afraid I've no visual here just at the minute, so I apologize to everybody for that, but welcome back to the second session. Just a reminder before we start that if you want to check that you're in speaker view for the presentation, it'll give you a better experience. And if you have any questions for the speakers, if you actually just put them into the chat function, we can ask them at the very, very end. I'm very pleased to welcome and introduce Nanette Moutry as our first speaker this session. She's Chair of Physical Activity for Health at the University of Edinburgh and directs the Physical Activity for Health Research Centre there. She has extensive experience of conducting interventions aimed at increasing physical activity and reducing sedentary time, with over 200 peer-reviewed publications. And the 5th edition of her textbook, The Psychology of Physical Activity for Health, will be published later this year. She's contributed to policy, for example, Let's Make Scotland More Active, and also the NICE guidelines on various aspects of physical activity. And she has advised Scottish Government on committees relating to physical activity and is currently chair of the Development Group for Sport and Physical Activity. A particular interest of hers is in how to communicate to the public, and she's chair of the CMO's expert group on communication of the physical activity guidelines. She's also received an MBE in 2015 for services to physical activity for health in Scotland. In this talk, Nanette will review the current evidence and discuss ways of helping people to move more and sit less. Thank you, Nanette.
Well, thank you for that lovely introduction, Lou. And it's always a delight to be with my colleagues in Belfast. But of course, I wish I was really there and not standing here in my temporary office in Glasgow as I am today. But I am trying to follow my own suggestion of sitting less by actually standing up here. So I hope this remains clear to you. And please do stop me because I think it's hard to chair these meetings on Zoom, and if I'm going on without time for questions being left, please remind me of that. I'll try to keep an eye on that myself. So thank you very much for inviting me to do this. I'm going to give you some of my reflections on how at this moment in time we should help people move more and sit less. And just before I really start, I wanted to talk about what COVID-19 has probably done. It's probably created more activity for some people. And as mentioned in the opening remarks this morning, for those who already had a habit, They would have gone and sought out ways to be active, but less activity for many others, those shielding or self-isolating, people who didn't live near attractive places to get out and be active, or those of us, and I would count myself in this, who are sitting more because we're actually working from home. And that is a negative side of it. I think if we had inactivity inequality, we'll have it bigger as a result of COVID. There'll be greater inequalities in those who can and those who cannot do their activity. But on the slightly more positive side, all of the chief medical officers of the United Kingdom have mentioned exercise in public forums to national audiences on television, in the news, as one good reason to leave home when we were on tighter restrictions. And that's not gone away. Nobody's stopped us exercising. And other countries have had that in their lockdowns. In Italy, you could not leave your home to exercise. So that's the positive thing. We've never had that high level endorsement of this being such an important thing that we'd be allowed to leave our homes. And I'm going to just touch on two other things that I think are positive. One is that there's new evidence that regular physical activity could boost our immune response. And I'll come to that just in a second. And the other is a new emphasis on mental health benefits during this time. So if I look at the immune response, I'm speaking here really on behalf of my colleague Seb Chaston. He's at Glasgow Caledonian University, and he very early on in lockdown realised there was a gap in our knowledge. If any time we needed to know about whether physical activity could help with an immune response, it was now. But we didn't have yet a systematic review on that topic. You know, and in our big picture of where physical activity relates to world health issues, we've been so deeply involved in non-communicable disease prevention, as many of the allied health professionals will be involved with, that we've almost forgotten that we do have a role in communicable disease. And so Seb and his colleagues have done this systematic review, and here are the key findings. And the two links are at the top in red, a paper that is a preprint. It is not yet peer reviewed, but the paper is in preprint there. And at the bottom, a YouTube presentation by Seb and others, including ourselves from Park, in which he talks through these results. So you can follow this up with him personally at his email. But this, for me, is game-changing. So his systematic review found that 30 minutes a day of moderate to vigorous activity, everything we know about, results in a 31% decrease in risk of infectious disease and a 37% decrease in risk of mortality as a consequence. A strengthening of the first line of defense in the human immune system. And some details there that I'll let you read. And an increase in the efficacy of vaccination. I mean, I think this is game-changing. You know, if there was a product that went onto shelves that said you can, roughly speaking, reduce your chance of infection by 1/3, people would buy it. I mean, do any of our public health measures we're currently all facing reduce the risk of infection by 1/3? I think this is a game-changing moment, and we should really be talking about this more. Of course, this is not my work, but I'm advocating that you follow this up and think about this in messaging. And then to mental health. In Scotland at the moment, we have a Clear Your Head campaign, recognising that COVID has created challenges for our mental health. And if you go onto their website, the very first thing that you come to when you press that little arrow in the middle of the screen is how to be active. Be active and safe outdoors, stay active inside, move a bit every day, have a good stretch, clear away the cobwebs. And that to me is fascinating, that we've come to the top of the list now in mental health advice during these times. So these are very good pieces of news for physical activity. However, there's still a need to help people move more and sit less. And in the rest of this talk, I'm going to describe or reflect, I think, on 3 ways that I think we can help. 1 is to see the big picture, 2 is to know the evidence, and 3 is to think about the message. So if we start by looking at the big picture, we have to go to the World Health Organization's Global Plan 2018 to 30. More active people for a healthier world. All sorts of good resources there if you go to their website. But this is the first physical activity plan that we've had from WHO. So we're still a novel topic, if you like, in the world picture. But the target that they've set from this plan is very, very ambitious. A 15% reduction in the global prevalence of inactivity by 2030. Wow, I think that's a really challenging target, but it will only work if all nations are involved together in trying to create it. And if we look at prevalence at the moment, and here's the world map of the prevalence of inactivity, we can see some of the issues. Of course, this is for women, and the orange is showing us that up to 50% of the population of women is inactive in our countries here. And there are some countries where more than 50% of women are inactive. And if we go to the next slide, we'll see a very similar picture for men, but immediately we notice that men are more active or less inactive than women, and our countries are now in the 30 to 40% prevalence rate. So inactivity is prevalent. Sorry, I'm getting a little feedback. Is it okay? Is the volume okay and everything?
Mm-hmm.
So the global picture of prevalence comes from this article in The Lancet in 2018, in which they show us that by their analysis, more than a quarter of all adults are not getting sufficient physical activity. The highest levels of inactivity are in Latin America, Caribbean, Asia Pacific, and high-income Western countries, which we are in. Men are more active than women globally, so there's an inequality that we're all concerned to reduce. But they're reporting no change in activity over time. And Western countries' inactivity is increasing during this time. So that means that up until 2016, there's no progress in reducing the global levels of inactivity. So that idea of reducing by 15% by 2030 seems a very big challenge indeed. Now, how does the risk of inactivity compare with smoking? Some of you may know this already. This comes from a Lancet article in 2012 by Aimin Lee, in which she looked globally at the rates of smoking. Deaths caused by smoking is around 5 million globally, and this is the population attributable fraction, almost 10%. If smoking were reduced to 0, 10% of deaths would be taken away. Now, that's the smoking data, and many of you may have seen this, but just before I show it, the blue bars of inactivity, is inactivity going to be higher, the same, lower than smoking? I know that if I went out into my street right here and said to people, is smoking riskier than not going out for a walk? I think they would say smoking. But in truth, when we look at the data that Lee collected, it's at least as risky as smoking, potentially a little riskier in both deaths caused in millions or population attributable fraction. So physical activity is risky, and I find this comparison to smoking a very good advocacy tool. So in summarizing that little bit, seeing the big picture, physical inactivity is risky and highly prevalent. That makes it a major public health issue. And so the best thing that countries should do is align with the WHO global plan. So on to the second reflection of 3 ways we can help people move more and sit less. Well, know the evidence of what works. And the best summary of the evidence comes from the 7 best investments, which was actually published alongside the Toronto Charter. But this infographic of it we helped produce from Edinburgh with ISPA, the International Association of Physical Activity for Health, the International Society of Physical Activity for Health, I should say. So it's worth just looking at how each of them plays a part. Communication and public education. Well, we're kind of doing a bit of that today. The transport and environment, maybe we missed that, but we're certainly seeing more of that in COVID, where we've got pop-up cycle lanes, we've got pavements being extended in space to let people actively travel. Let's hope they remain permanent. Design in urban areas about safe places for recreation. And I remember, of course, in early days of lockdown, Marie in particular was having to do a lot of advocacy about opening the parks so that people could actually go out and be active in your local areas. Healthcare and education, exactly your domain, and you're doing all that you can, I'm sure, to improve the physical activity of patients and to educate about it. Then the education sectors itself, in schools and colleges, are we making physical activity a part of learning and easy to do? Community-wide programs, of course, and in sport and recreation, systems that are more about participation than performance, a sport for all approach. So this 7 best investments suggests to us there is no silver bullet about how best to help people move more and sit less. All of these things have to be working to make that shift in the population levels. But if I had to find something that maybe wasn't a silver bullet, but maybe just a kind of bronze bullet, it would be to promote walking. Because walking for me is the most equitous mode of activity. So it has the least variation between the affluent and the less affluent in our societies. Walking is the least gendered mode of activity. And while we'll still have a bit of a gap, it's very close between men and women. Walking is the least ageist mode of activity. It's not such a steep gradient of decline between the young and the old here, as we do for other kinds of activity like sport. No skill needed, no equipment needed, and it fits into lifestyle, which is what the guidelines are always recommending that we do. Something's better than nothing. You can add it up over the course of the day. And so it works very well from these points of view. And many infographics exist about the benefits of walking, and this one is for 30 minutes a day. And, you know, at the top, we've got reducing risk of heart disease, and interestingly, down at 20, boosting immune system, you know, certainly without perhaps the evidence we have for other areas. But what this is saying is that walking can provide the benefits that any kind of physical activity can have. And that's why I think it's important to promote walking as perhaps the best way of progressing. And in fact, in Scotland, our walking charities have set out a statement of how to build back better from COVID and towards a new normal, and sets out how walking and wheeling, and of course, this is where we have to take account of people who may not be able to walk, who may be in a wheelchair, and that includes them in this kind of statement. And our Active Nation Commissioner, Lee Craigie, says promoting walking should be done in an equitable way across communities to support a reduction in health inequalities. And that statement can be found here at the website I've given you. So walking has been picked out as one of our post-COVID recoveries, if you like, not only for our health, but for our communities and for the ability to use safe streets and cycling lanes. And if you want to follow up a little bit more about what I think about that, there's a podcast here that you can follow that was done with the British Journal of Sports Medicine, where I'm making the case that maybe walking is the best buy for public health. So when we've looked at the evidence of how to help individuals increase walking, we've done a lot of research where we've used pedometers. And pedometers help people with goals. And the key thing is that they're graduated goals over time. It's not start next week and do 10,000 steps, because that 10,000 is not that useful as an initial target. Many people, indeed my colleagues, we had a little debate about that last week on our meetings. One colleague had done less than 2,000 steps in a day because of working at home. Everyone with a dog had done a lot more. So there's an interesting point for you to think about in this process. But 2,000 steps is normally associated with people who are frail and not able. And here we are in these particular working at home moments where we're getting very few steps. So if you start at 2,000, 10,000 is a long way off. So it's got to be graduated up, and we've been successful in using that approach to help people walk more. And I'll just give you one little example of that kind of research done with people over 65. And we took them, we recruited them from their own GP practices, and we did a 12-week program with them, and we were measuring their activity by ACTIVE-PALs. Now, an ACTIVE-PAL is a little research level device in which the participant cannot see outcome from it, and it is located on the thigh. And so people are, this particular device can measure sitting and standing postural activity very well indeed, as well as steps. So the green intervention group had a little consultation with the practice nurse, and were invited into a gradual program of increasing their steps every couple of weeks. And after 12 weeks, they went from just over 7,000, which is admittedly is quite high. They were able people, up to just over 9,000. In the meantime, the control group, who were asked just to carry on as normal, didn't do much change. But they then got the intervention at 12 weeks, and they too increased by the same amount. And this nice rhomboid pattern is a nice thing to see. So the second time the intervention is repeated with the control group, you get the same increase. And the good news was that the intervention group here did not decline after the 12 weeks. They had found a way of keeping that going. And then when we look at the sedentary time, which the ACTIVE-PAL measures very well, this is minutes of day, we see a very similar pattern. So the intervention group initially decreased by 48 minutes a day, and then when the control group started the intervention, they had a very similar decrease. So interestingly, using a pedometer and encouraging people to accumulate over the course of the day seems to have an impact on sedentary time as well. It gets them up. So this is moving more and sitting less when we do it this way. And that brings me on quite nicely to the guidelines about sedentary time, which we have in the UK for children, young people and adults. They should be minimizing the amount of time spent sedentary and break up long periods of activity with at least light activity, which is perhaps what we showed in the previous study. But we don't have any threshold to aim at. So the truth for me is, and I've just lost the ability to move to the next slide, I've got it now, there's increasing disbenefits of sitting for long periods of time. For example, in increasing all-causing cardiovascular disease mortality, type 2 diabetes, or the mental health issues, anxiety, depression, sleep disorders, and lowering levels of emotional well-being. So it's increasing evidence that sedentary time is independent in this way from physical activity. And what we know much less about, however, is how to alter that sedentary time pattern. So at best we've got, and I thank my colleague Claire Fitzsimons for this summary, are the top tips from what we've gleaned from our research at the moment. How do we break up long periods of sedentary time? Stand or walk while on the phone, or now during video meetings, we all have to invent a way of having a standing desk so that we could stand at least for some of the time. Cooking from scratch, people say this helped them sit less, to really spend time doing that. Going for a walk or stretching, watering the plants. And if using public transport, of course, it's not advised at the moment, can you actually stand for some or part of the journey? Using the commercial breaks to get up and move about, or set a timer on a fitness tracker to remind yourself. So these are just the top tips, but our intervention research in this area is behind what we know for how to improve physical activity. We don't yet have great definitive answers about how to break up sedentary time. And this leads me finally to what I describe as the forgotten guidelines about muscle strengthening and balance for adults and older adults. We can't miss this out when we're thinking about helping people move more or sit less. They're forgotten because the main thing that we're always talking about is that 150 minutes, but all the allied health professionals will know the functional benefit of gaining strength. And yet, in terms of public health, we actually know almost nothing about how to achieve this. It's an extremely difficult public health issue to promote strengthening. Now, you particularly asked me to talk about a little project that I've put into my own park, because, to gain strength, perhaps the most efficient thing is to go to the gym or to do a series of exercises at home. That's really hard in terms of messaging for public health, in terms of compliance, adherence, motivation to do that. And in parks, we've seen some places where they've got these lovely green gyms. Frankly, I rarely see adults using them. I see kids playing on them. They kind of look intimidating unless you know about how to use that equipment. So I came up with this idea that we'd just have a little sign that we put on our existing park furniture. And I've got 9 of these. And the first one is the sit to stand. And they each look exactly like this, as I'm showing you on the screen. And they're placed in park furniture in my own park here. And this is me last summer introducing the kids. The kids loved sit to stand as much as everyone else on a lovely sunny day in the park where I live. But this can be all sorts of things. We've got a bench press for strength. And, here's my vision. Any park, any time. I give you all these PDFs and you can install them in your own place if you can. It makes people aware of the possibility of strength. It sort of fits it into everyday activity when people are out walking anyway, and it's not intimidating. Now, whether people will do it or not is, of course, another question, but this is something that I'm now seeing other places in Scotland are using this exact thing on walks, on health walks and on walking groups to include strength as part of that. And this is the balance part. There are some balance exercises as well to do. So in terms of what do we know, we should promote the 7 investments. And I think walking's the best bet. We know much less about how to promote sitting less or building strength. So much more work needed there. Last thing then, and I hope I'm still on time for some questions, is to think about the message. Now, should we focus on benefits or warnings? Right, Marie, your ears are going to burn here now, because in this paper published as a special edition of the British Journal of Sports Medicine, it was particularly focused on walking. So I'm back on my hobby horse, if you like. we've got an example of contrasting messaging. So this paper talked about the need for faster walking to reduce the risk of mortality. Now, to me, that's a warning, not a benefit. And I just wonder if that kind of take-home message, emphasize faster walking pace to reduce mortality, is going to work with the public. And when I look at this, I want to pick out something else. Up here in the corner, walking at an average, brisk or fast-paced was all associated with this. I would like to see the public health message being walking at an average pace is good. But this has been our common style, to use the risk of not being active as the message, and I don't think that is right. Another article, of course, I was involved in the second one and not the first one, so you know where my bias is, was in that special issue was walking for mental health. And I want to pick out this: walking may improve positive mental health outcomes such as happiness and self-esteem, something much more reachable today, tomorrow, and the next day from any amount of walking. Of course, we were also pointing out that we've had an increase in the amount of evidence about walking and mental health since the seminal 1997 article on walking for health published by Morris and Hardman, which this special edition was celebrating. But this is a positive message, and this one too, walking outdoors in natural environments brings additional mental health benefits. You know, that can be done today, tomorrow. So that's a stance, but in fact we've now done a scoping review on what messaging is best. And this is work that we're pursuing at Park in the University of Edinburgh. What did we find when we did this? Physical activity messages should highlight short-term and immediate benefits. And social and mental health benefits are found to be preferred. Messages should be customized for recipients. Of course, you all know that very well, but we're not doing that all through it very well. We need messages for older people, younger people, those with abilities, those with disabilities. But if resources permit, we found from our scoping review that we should try to use formative research. We shouldn't just go, oh, there's a great idea, and make it public. We need to use theory from psychology or social marketing to inform the design and delivery of that. So my final message is, think about how we say what physical activity benefits are for people, because it will make a difference, I believe, to their motivation. So I think I've managed to do that on time, but I know there may be questions or comments, or you can contact me on Twitter or by email. And in the next slide, there's the set of resources or references that you can follow up, because the slides will be made available to you. So thank you for that.
Thank you very much, Nanette. That was very useful and very, very interesting. I think too often we forget that we think that because walking doesn't sound as exciting and we're not spending a lot of money, that it isn't going to benefit people, or it's not going to be as accessible. And I think we forget about that. One question I would have to ask for you, I know you worked with the parks, the councils on the park project. How did you get them engaged?
It was very easy, because we weren't asking them for any money, and all we asked them for was the permission to put the signs onto the park furniture, and they were very happy with that. We did it all ourselves, and really it's cheap as chips. And other places that have now taken those same signs and put it into their walks, one most recently at Forth Valley Health Board Hospital, which has a walking route round it. They've put the strength and balance exercises around their walking route for very little expense, under £1,000 for that.
Yeah, I think it has great applications for those of us working in the health service to use around our hospitals, both inside and outside. In terms of assessment, have you been able to assess the impact of it?
I haven't. I confess that I don't really know how to do that. The best thing that I've come up with, and Forth Valley Health Board are doing it in this hospital walk, is to have a little QR code, and people link on that with their phone and do a little survey for them at that time. But because it's out in the real world, and unless you have a person there observing day after day, this is a very difficult thing to evaluate. I see people using it in my own park, but that's as far as I've gone, you know, and that's a tricky one for me.
I think it sounds wonderful. I think it's an easy one for people to replicate. So no doubt everybody will be looking for the PDF files with the images.
They would be very welcome.
Thank you very much for that, Nanette. And again, I think if anybody has any additional questions, if you put them in the chat, Nanette will probably be able to answer them afterwards for us. So we'll move on to the next speaker for this session. Is Tom Maiden-Wilkinson. He's a muscle physiologist with a research interest in strength training and older people. He works as a senior research fellow in the Physical Activity and Public Health Research Group at the Advanced Wellbeing Research Centre in Sheffield, and runs the Strength for Life programme, coordinating physios and occupational therapists together with strength and conditioning coaches and exercise scientists to enable older adults to safely undertake strength training. In this talk, Tom will discuss sarcopenia in the context of frailty and present some of the key and emerging interventions. Thank you, Tom.
Thanks very much, Lou. Can you see my slides okay?
Yes, we can.
Okay, great. So thanks very much for the invite. I really wish we were over in Belfast and spending some time in Northern Ireland. Nanette, I think you've just lined my talk up really nicely, so thanks for that as well. So just kind of in terms of my background, as kind of Lou said, I'm a physiologist, so I'm not a physiotherapist. I don't have a clinical facing role. I sit in the Advanced Wellbeing Research Centre in Sheffield, and my colleague Anna, who is next on the bill, will speak to you more about the role within that as part of the National Centre for Sports and Exercise Medicine and Move More as well. So in terms of just the kind of outline of the talk, I'm just going to talk around specifically the strengthening guidelines that Nanette just brought up. What is muscle strength and why do we care about it, and how we can go around assessing that, especially with a slant towards older adults and long-term conditions, and then examples of how we can manipulate that into strength training programs. So as we just kind of heard from Nanette, that there is the kind of strengthening guidelines as part of the Chief Medical Officer guidelines that got released last year. And really positive from kind of my point of view is that there's really this kind of push more towards building strength. You can see it's really fitting quite nicely now within the kind of message. So not only focusing around the 150 minutes of moderate intensity exercise per week, but really pushing on this building of strength. And especially in the goal in terms of older people to improve muscle function and bone health as well as balance. And you can see, and Nanette kind of introduced it quite nicely, that the actual proportion of people meeting those guidelines is really low. And that was really encouraging to see the Parks project that she's got going on. So again, this is taken from the Chief Medical Officer guidelines about different activities that we may be able to kind of take part in to help improve our muscle function, our bone health, and our balance. And you can see the kind of rated around the strong effects from the research literature in 3 stars down to 1 star for low effect on those. And in particular, from a research perspective, I'm interested from this resistance training angle and how we can manipulate that into different groups. Now, the reason that's important, if we look across the kind of lifespan, is that we kind of have this real peak in our muscle strength, and this is the same for bone mass as well in our early working age, so our 20s and 30s. And then we see this marked drop off as we get older. Now, there's certain cut points, and depending what we're looking at in terms of muscle strength, we can start to see declines from our mid-30s. Now, there's a kind of argument that if we are successfully aging with good health and maintaining our strength and balance, so we have a good peak in our muscle strength and balance to start with, then we can stave off quite a lot of potentially the disability events that may cause in our later life. But you can see if we're not particularly productive in doing those strength and balance activities as kind of part of our middle age, as we get older, we drop below what was termed this capability threshold or a disability threshold. So this kind of puts it in terms of a population level focus that we should really try and kind of emphasize the points of our kind of 20s, 30s and 40s of trying to maximize our muscle strength. And the term that we use as kind of part of the Strength for Life thing is maximizing our strength bank account to rely on our pensions as we get further down. We want to live a good and healthy older life. Now, muscle strength, we're not just thinking of a whole host of different activities, but different activities require different amounts of strength. And there's a really great app that you can download in the App Store called the Life Curve app from Newcastle University Institute for Aging. And you can essentially work through with your patients or with yourself to see what your strength levels are and whether you're reaching this optimal curve for aging, where we maximize our independence for as long as possible, or we're following this kind of sub-optimal curve. And you can do this progressively over time to see how well you're improving. So you can see there's a number of different activities that require a whole host of different amounts of muscle strength, from hiking and brisk walking at the top that we would consider people really to be independent, through to needing slightly kind of less strength to be able to move around our own house, and then to be able to eat independently as well. So if we're thinking about this as a population level and why this is particularly prevalent, is that we know we have this aging population. So over the kind of next 40 years or so, we'll see an increase in the number of people aged over 65 as a proportion. And we have this progressive loss of muscle mass, or strength and function, that in the research literature is termed sarcopenia. And this is related to an increase in falls risk, a reduction in mobility, and then essentially loss of independence. We know this is the effects of it are magnified by physical activity, and sarcopenia is a lot more prevalent in long-term conditions. And associated with that, there's an increase in healthcare costs. So there's a recent health and economics paper published 2 years ago that showed that muscle weakness costs the NHS around £2.5 billion annually. So in the context of frailty, we can see that there's sometimes in the research literature they're used interchangeably. However, sarcopenia is essentially just the loss of muscle mass and strength. There's obviously a whole host of different varieties, different conditions that may cause frailty a part of it. But in terms of the sarcopenia prevalence, you can see from the graph here, as we get older, our prevalence of sarcopenia increases as we might expect. And if we're thinking about muscle weakness, we can think of a chronic decline, so a slightly more sedentary behavior as we get older, contributing to this. But we can also think in the context, probably more of what you're used to, in terms of an acute decline. So that's impaired muscle healing or muscle recovery. And that might be from falls or fractures. It might be topically from social isolation and safeguarding ourselves. It might be through hip or knee replacement surgery that lead to prolonged bed rest, which kind of proliferate this muscle weakness. So overall, in terms of sarcopenia, the classic definitions were focused around the loss of muscle mass, but more emerging evidence has shown that it's actually strength that should be kind of more pushing as that declines to a greater rate, and as well as muscle power. In terms of being able to screen for that in practice, so this is the European working group on sarcopenia as a group. So they optimize screeners using something called the SARC-F questionnaire, which I'll show you in a minute, as well as a strength assessment. That can either be isometric grip strength using a handheld dynamometer, and there's cut-offs for men and women, as you can see there, or using time to complete 5 sit-to stands. So if you take over 15 seconds to complete 5 sit-to stands, we can probably confirm that someone is sarcopenic. In terms of the research literature, and academics really like to complicate things slightly further, is that they would recommend that a muscle mass assessment. I don't think we're going to suddenly get away with sending loads of people through for DEXAs to measure their muscle mass. But what we can do in a clinical setting is measure their functional assessments, either through the SPPB, a 400-meter walk, or timed up and go. So in terms of what we can do within a clinical scenario, we can focus around strength assessment, but also use this SARC-F questionnaire. So this was developed around kind of 7 years ago. And there's a link here to how you can download that as part of the CGA kit from Ireland. So you can see it's a really quick set of 5 questions that you can ask your patients or participants and get an indication of whether they are sarcopenic or suffering from poor physical function. So we can ask them about their strength. Do they have difficulty in lifting and carrying 10 pounds? We can take that to a heavy shopping bag. We could ask them if they need assistance with walking or rising from a chair. Are they able to climb stairs, or how many times have they fallen? Something that's really quick and easy for us to do within clinical practice or within a conversation with participants. So there's a whole host of different physiological reasons why we have this loss of muscle mass, and particularly the loss of muscle strength and power as we get older. You can see from the MRI scans of the thigh, we have an older person here and a young person. We see a reduction in the muscle mass in total. We see an increase in the fat infiltration within the muscle. This might be really good for your sirloin steak in terms of the taste, but not good for force production. And part of that infiltration also helps to drive kind of a systemic inflammatory response as well. And we also know muscle, as we get older, becomes less anabolic, so it's not as sensitive to anabolic hormones and indeed to protein feeding. The reason we get a greater loss of muscle strength is primarily neural control of our muscle. So we have a loss of motor neurons that is preferentially our faster motor neurons and faster motor units. So we have a higher proportion of our slower type 1 fibers. We see a reduction in our conduction velocity within the nerve itself, and a decrease in how well we can recruit our muscles. So going back to this idea around strength assessment, so the working group suggests to look at grip strength and 5 sit-to stands, and I'm going to show you the evidence for where that comes from now. So in terms of grip strength, we see this characteristic loss of muscle mass from our peak and from our kind of mid-20s and early 30s through this characteristic loss of muscle grip strength as we get older. And that occurs both in men and women. So we expect values to be females to be slightly weaker than men, but men we tend to see a much larger drop-off. And really interestingly, from a recent study from Denmark, you can see that the kind of trajectories of hand grip strength very similar to the UK data that I just showed you, but the decline in our leg power is much steeper than that. So preferentially, when we're thinking about programming, is that we focus particularly probably more on the lower leg. To kind of back up the story around the importance of muscle strength, we don't tend to see a whole host of changes in the amount of muscle mass in the arms and legs in this study, and that's typical from different cohorts as well. So our kind of answer, and our best answer to this is around progressive resistance exercise and strength training in particular. And that's different depending on who we've got in front of us. We might have the world's strongest man and training to maximally lift as much weight as possible. We might have the world's strongest grandma in this case. But muscle strength and muscle strength training can look different for everyone, whether it's use of TheraBand, whether it's use of arm and ankle weights, whether it's seated or standing, or whether it's just developing enough strength to be able to rise out of a chair or wheelchair. But when we're thinking about strength training, there's three key principles that we need to consider. The principle of specificity, so try and be as specific for the outcomes that we want. We want to overload the muscle to allow a training adaptation, and we want to make it as progressive as possible. So we would say when developing strength training that we want to try and target specific adaptations, through increase in loading and progression of exercise that's appropriately modified for your client or patient's level of ability. And a real quick way of kind of showing this might be in a sit to stand. So we might start with a sit to stand and we look at different progressions or maybe regressions as part of that sit to stand. In terms of progressions, it might be that we move the feet further away from our base of support, or indeed we provide some support during the sit to stand maneuver to help maybe steady a more frail participant. But in terms of the research literature, in terms of getting the most kind of bang for our buck from strength training, we want to try and perform movements that are really specific to our activities of daily living. If we're struggling to walk up and down stairs, then we should focus on the muscles that are used to walk up and down stairs, primarily the quadriceps and the glutes. If we are thinking from a gym scenario, we want to try and focus on multi-joint movements. That might involve machine weights for beginners. And we want to try and work up towards kind of 3 sets per exercise with 2 minutes rest. As I spoke about before, we can progress and regress those movements according to your patient or client ability. But try and have in mind this idea that we want to try and overload the muscle. They're working towards a higher intensity, and we might want to try and overload different functional tasks, whether it's using dumbbells or weighted vests or other resistance that we might find around the home. And we maybe want to try and split this over a total body routine over kind of 2 to 3 times per week. Now, we're not just using strength training. There's obviously impact on our muscle mass and strength and the role in impairment. And indeed, that's kind of our primary role. But there's also carries over to a whole host of different other long-term conditions. We know, for example, in cancer, if we perform resistance training twice per week, we see a reduction in the risk of cancer mortality and also all-cause mortality, and that's over aerobic training alone. And as well as seeing improvements in chemotherapy and radiation therapy side effects. In terms of cardiovascular disease, something that we would normally typically kind of consider aerobic exercise for, resistance training shows comparable reductions in blood pressure and lipid profile, as well as vascular function as well. And similarly with type 2 diabetes, we see improvements in glucose control as part of resistance training studies. So if we're thinking about considerations and especially with different population groups in front of us, we might actually want to consider using muscle strengthening activities and balance training before we start to progress towards aerobic training, especially in very frail adults. In my opinion, we should consider chair and bed exercises as a kind of starting point in very frail adults rather than the kind of norm for older adults as well. We consider different limitations of your individual clients and patients, and also some of the contraindications to resistance exercise as well. Predominantly, these could be around vertebral osteoporosis or uncontrolled cardiovascular conditions. We can adopt this multidisciplinary approach, and this is what we've done as part of the Strength for Life program, involving physios and occupational therapists, as well as exercise scientists and nutrition to kind of fulfill a much more holistic program. And in terms of our muscle health, we want to try and avoid bed rest as much as possible. And some really kind of key emerging surgery key emerging evidence is trying to maximize our muscle strength and mass prior to surgery, especially in the context of hip and knee replacements, and especially with the waiting lists that are currently ongoing. So I welcome you can contact me through Twitter and also my email. You can access any of the research publications through my ResearchGate. And feel free to get in touch and ask any questions on there. Thank you.
Thank you very much. I believe Tom is still on the call. Tom, are you available for a couple of questions?
Hi, Lou. First of all, I'm so sorry about my internet connection in South Yorkshire. Apparently it's gone on lockdown.
Well, well, you did sterling work with Kyle and Angela in getting it ready in time so that we got to hear the rest of it. There's nothing in the chat here. Probably people didn't realize in time that you were still with us. But if I just ask you, in terms of, obviously when we think of strengthening, things like that, we think of equipment and gym and, costly sort of interventions that maybe aren't accessible to all. What would you recommend in terms of easy to access, free to do exercises?
Yeah, I think Nanette touched on it before. For most people, and to kind of not to generalize that all people over kind of 65, but body weight is more than sufficient for most people. So utilizing body mass, and if they do tend to find that relatively easy, then you can look at overloading that in different ways, whether it be kind of things around the home, or kind of, as I alluded to in the talk, just changing the exercise slightly to kind of make it slightly more difficult. In terms of kind of when to progress, we tried to say to aim between 8 and 12 repetitions. If someone can do an exercise for 8 repetitions and then can't do any more, that's a good indicator that they're working hard enough for adaptation. Once they're able to perform that movement 12 times, then we can start to look at making that more difficult. And that ensures that we keep that progressive overload stimulus throughout.
I have another question here from Lisbeth Preller. What do you advise on protein intake during training periods? So like classically, we would say to try and increase protein intake, not only just during training periods, but for all older adults. If we take in the recommended daily allowance of that kind of 0.8 grams per kilo, it's just about sufficient, but I think we should try and aim to kind of be slightly higher, and especially during strength training, that will help try and promote a hypertrophy adaptation. One thing to consider with that, and I'm sure your nutrition and dietetics support will kind of concur with that,
is that we do have that satiety influence of protein as well. So kind of monitor that, that we're getting sufficient protein, but if we are increasing protein, then we still maintain a higher energy intake as well.
Yeah, and one final question here from Sophia Marini. Which barriers should we take into consideration in order to promote muscle strength exercise in older people?
So I would say we can do muscle strength training exercise pretty much in everyone, whether we have to adapt that to bed-based exercise or chair-based exercise beforehand. There's a number of conditions, especially anything that's particularly unstable or not controlled very well with medication, that we maybe want to take into consideration for resistance exercise, and especially unsupervised resistance exercise. There's some fascinating work by Dawn Skelton that around the kind of use of resistance exercise in osteoporosis patients and when it's safe to kind of progress that as and when you need to.
Listen, I'd like to thank you very much, Tom, and I'd like to hand back to Marie at this point.
Okay, folks, it's 1:35, so welcome back. Hopefully you had a chance to stretch there and take a bit of a break. As you've probably gathered from Tom, he was having some internet difficulties. We have checked that it isn't a problem at our end, but it does seem to be a problem when he tried to share his slides and speak to us. So I do realize that you've missed out on the very end of his presentation, but we are endeavoring to get that for you. So sit tight, hang fire. We will have the remaining part of Tom's presentation available soon. Meanwhile, and I now feel like a BBC continuity announcer, in a change to the scheduled advertised program, what we're going to do is jump ahead to some of the other ACTLIFE presentations before returning to Anna Lowe at the scheduled time of 1:50. So we're going to use this gap here to do 2 of the 3 remaining ACTLIFE presentations. For those who weren't here at the start, ACTLIFE is an Erasmus Plus funded project, European-wide, that's looking at the tertiary and secondary prevention of osteoporosis using exercise. It is a collaboration led by the University of Bologna. Ulster University are pleased to be involved in it, and it also includes partners from Finland, Republic of Ireland, Bulgaria, and Germany. And it's our German partners that I'm welcoming now. They kindly pre-recorded their presentation for us. So they have 3 short presentations, 2 of which we will do now. The first of these is by Michael Hetchen, and it's the presentation of their randomized controlled trial. So you did hear Giuseppe earlier presenting the Italian randomized controlled trial. A different protocol was tried out in Erlangen in Germany, and Michael is going to present the findings of that trial.
Friendly hello from Germany. My name is Michael Hetchen, and I was, among others, responsible for the realization of the randomized controlled clinical intervention study in Erlangen, and will now present the contents of this study to you. Let's start with the inclusion and exclusion criteria of the intervention. The requirements of the participation in the study were these 2 points: women in the early postmenopause with osteoporosis or osteopenia in the lumbar spine or femoral neck bone. What were the criteria that prevented participation in our intervention study? The bone mineral density T-score of less than 4.0 or a clinical low traumatic fracture. Diseases and drugs with relevant influence on bone and muscle mass or cardiometabolic risk factors, severe cardiovascular events in the past, factors that forbid physical activity, and absence of more than 3 weeks during the study period. The next slide gives us a nice overview of the flow of participants during our intervention study from the acquisition to the evaluation of the final results. 2,500 women between 48 and 60 years living in the area of Erlangen-Nuremberg were contacted by letter. Out of these women, 332 were shortlisted and examined for the inclusion and exclusion criteria. 257 women were excluded due to the exclusion criteria just mentioned. The remaining 54 participants were randomly allocated to an exercise group and a control group. 6 in the exercise group and 7 in the control group were lost to the follow-up measurement after 13 months of training. All of the 54 women were included in the intention to treat analysis so that all participants were included in the final results. The control group completed a 45-minute training once a week with stretching exercises, light functional gymnastic, and contents of yoga. In the 13 months, the group had 3 blocks of 12 units each. Between these 3 blocks, they had to complete 50 minutes of easy functional exercise, which were performed and animated in a video. The training group had 3 training sessions of 40 to 50 minutes per week. The training was made out of 2 alternating blocks. One block had been over 10 to 12 weeks with intensive power and strength training, and the other block had been with 4 to 6 weeks of endurance training and high volume and low strength training. Every participant of this group received an individualized training plan. Both groups, which means all participants, have got vitamin D and calcium substitution. The next slides show the final results from our outcome variables and the changes after 13 months of training. First of all, bone mineral density, lumbar spine, and lean body mass measured by the DXA device. The example on the DXIs is shown on the photo here on the slide. On the left side, you see the changes in percent of the bone mineral density at lumbar spine, which was our primary study outcome. On the left, the exercise group, and on the right, the control group. For clarification, the asterisks of the result slides above and below the standard deviation, which you see here, shows if the change within the group is significant. The asterisks between the bars, which you see here, show the significance of the group differences. The primary study outcome, bone mineral density at lumbar spine, was maintained in the exercise group and decreased significantly in the control group. The lumbar spine bone mineral density changes differ significantly between the two groups. On the right side, we have the changes in percent of the lean body mass. Lean body mass increased in the exercise group and decreased significantly in the control group. Difference between the group changes were significant. Now we consider the changes of the body composition. Total body fat on the left and the cardiovascular risk factor abdominal body fat mass on the right. As well, total body fat as abdominal body fat decreased in the exercise group, which you see here, and was maintained in the control group, which you see here. Changes between exercise group and control group for total body fat and abdominal body fat were significantly different. This slide refers to the performance variables we have measured. Jumping height, determined by a force platform, and hip leg extension strength determined by an isokinetic leg press. Maximum leg press and jumping performance increased significantly in the exercise group and improved only slightly in the control group. Difference between the groups were significant for maximum hip leg extension strength and lower extremity power. On this slide, we see the changes of cardiometabolic risk as determined by the metabolic syndrome Z-score from baseline to 30 months follow-up. The metabolic syndrome Z-score was maintained in the exercise group and worsened in the control group. However, pre to post intervention changes in the metabolic syndrome Z-score did not differ between exercise group and control group. Menopausal symptoms, as determined by the menopause rating scale 2, improved in both groups. However, the changes from pre to post intervention were only significant in the exercise group. Further significant between group differences for menopause rating scale were observed. We had to stop the study due to the Corona lockdown, but I'm very happy that after 13 months of this complex intervention study, we have measured such great results. Many thanks for your attention, and once again, many greetings from Germany.
Okay, I'm going to thank Michel, not Michael, in his absence. That was a recorded video. What I tried to do into the chat bar was to highlight some of the significant changes, because we won't have an opportunity to question Michel. But what I will say is that the paper based on that randomized control trial is currently under review and should be in press within the next few weeks. So if anyone is particularly interested in following up, if they drop me an email, I'll be able to send you that paper or answer any of your questions. The second of three presentations is by Simon von Stengel, and Simon has done a pan-European survey, or we all contributed to it, but Simon coordinated it, to look at what people are doing or what they're recommending in terms of exercise in the secondary and tertiary osteoporosis prevention space. So we in UK and Ireland, we looked at what was available and what was current practice, and they did likewise for many countries in Europe, and Simon will now present that work.
Hello everybody, my name is Simon von Stengel. I'm working at the University of Erlangen in Germany, and I will talk about our analysis of European experiences and practical implementation of exercise programs for secondary or tertiary osteoporosis prevention. In the clinical practice, physicians recommend the patients mostly simply to be more physically active or to perform some exercise. However, exercise is not like a pill where you can simply take 50 milligrams a day. So exercise recommendations for osteoporosis have to be much more specific. Especially exercise is not exercise, and some kinds of exercise are effective for osteoporosis, some are not. Like you can see in the meta-analysis down there, swimming and cycling do have no positive effects on bone mineral density. So we analyzed the European experience. We reviewed the literature for recommendations, collected some data, and assessed the implementation status of recommended exercise protocols in the field of osteoporosis. We searched for guidelines of European countries for recommendations and policies in the area of exercise and osteoporosis, or exercise and fractures. We assessed the status of the implementation of osteoporosis-specific evidence-based exercise protocols in public health settings or other broadly disseminated everyday practice training settings. We analyzed the recommended exercise protocols and did some exertion of promising exercise types or exercise compositions in order to generate specific exercise recommendations for work package 3 of the ACTLIFE study, which means the ACTLIFE protocol development. So I want to summarize the results. Corresponding institutions, facilities, or peer groups emphasize the favorable effect of dedicated exercise protocols on fracture prophylaxis and or secondary or tertiary prevention of osteoporosis. However, most of exercise recommendations are not comprehensive or specific enough to derive differentiated exercise programs for different cohorts at risk for or with clinically manifest osteoporosis. But most important, there is a lack of implementation of evidence-based standardized exercise protocols in everyday training practice. So we took the results or the recommendations together. So what training is the best for whom in the field of osteoporosis? So people with osteopenia without increased fall risk should try to maintain the bone strength or mass, or even to increase bone strength or bone mass, which means they should perform a high intensity bone loading exercise program. The same for people with osteoporosis without increased fall risk. But the intensity has to be a little bit less intense. People with osteopenia, osteoporosis, no fractures, but multiple risk factors for falls should also focus on falls. They should try to reduce the fall frequency or reduce fall-related impact on bone by improving fall strategies. People with vertebral fractures and multiple risk factors for falls should, of course, try to maintain bone mass. However, the training may not be too intense. However, the main focus should be on the reduction of fall frequency or the reduction of fall-related impact on bone. People with multiple fractures, with high risk of falling and a very low physical capacity should only focus on falls. So we took together exercise recommendations for osteoporosis with respect of bone mass or bone strength. So when applicable to positively impact bone, you should focus on high intensities. You should periodize the training, perform a resistant training or power training at an intensity of 65 to 90% of the one repetition maximum. All muscle groups should be trained to impact all bones of the body. You should try to generate high strain rates, which can be done by performing aerobic dance, high impact aerobic dance, or high impact dances, jumping, gaming, resistance training with a high velocity during the concentric phase, which means power training. You should try to generate unusual strain distribution by performing, for example, aerobic dance, jumping exercises, or gaming. You should try to realize an adequate training frequency, which means at least 2 sessions per week at a duration of 45 to 60 minutes for each session. You could do a block periodization in order to provide adequate rest periods and to apply optional other training aims like endurance for the corresponding cohort. And training should be performed as group session and should be consistently supervised. So I thank you very much for your attendance and I wish you a nice and interesting day and stay healthy. Goodbye.
I'm delighted to introduce Anna Lowe. She's Programme Manager at the National Centre for Sport and Exercise Medicine at Sheffield, and also the lead Allied Health Physical Activity Clinical Champion at Public Health England. She's a chartered physiotherapist with a special interest in physical activity and healthy ageing, and she worked in the NHS for many years. This was followed by policy roles at Public Health England and NHS England. And she now leads a number of large collaborative research projects alongside Sheffield's physical activity strategy, Move More. In this session, she will review and summarise the key evidence and guidance for physical activity in the prevention and management of long-term conditions. Thank you, Anna.
Hi everyone, sorry I just lost my unmute button because I've started sharing my screen. Thank you very much for the introduction. It's lovely to be here today. I'm delighted to have the opportunity to talk to you all. So I've got about half an hour I think to talk to you, and then I'm very happy to take any questions at the end. That was a lovely introduction. Thank you very much. So I don't think I need to talk too much about who I am and what I do, but I will just pick up on a couple of key points just so that you can understand my perspective and where I'm coming from when I talk about embedding physical activity into clinical pathways. So I'm a physiotherapist by background, and I can't miss the opportunity to say happy AHP's Day to everybody who is an AHP on the call. So I'm an AHP at heart, even though I haven't practiced clinically for a long time. But I think those formative years in clinical practice in the NHS and in private practice have really shaped my thinking around how we can embed physical activity into clinical pathways, and how we can, as health and care professionals, how we can intersect with other parts of the system. So I, in addition to being a physio, programme manager at the National Centre for Sport and Exercise Medicine in Sheffield. This is an Olympic legacy project. It's a partnership between 12 organisations across Sheffield who all share an ambition around embedding physical activity into the fabric of Sheffield and creating a culture of physical activity in Sheffield. The way that that ambition is sort of operationalised is through our Move More plan. I've got our plan on a page up on the screen at the moment. We're currently writing our next strategy, so looking at the original strategy and how we might sort of develop that further. But I don't know if you can see the 6 areas of focus, the 6 sort of key outcome areas at the top. So we've got empowered communities, active environments, active people and families, activity as medicine, active schools and active workplaces. And so the activity as medicine, we now talk about our Move More Health and Social Care sub-theme rather than activity as medicine, but that's an area of physical activity intervention that I'm particularly interested in. In addition to my day job at the National Centre, for the last 3 years, I have been one of the lead physical activity clinical champions for Public Health England. I've actually stepped away from that role, and one of my colleagues, Sarah Dewhurst, has taken on that role. So that programme is still going from strength to strength, but I'm no longer in post. So I just wanted to mention that. From a research perspective, I'm really interested in how the system makes it easier for people with health conditions and people who face barriers to becoming more active, how we can work together as a system to make it easier for those people to become more active. I have to just sort of apologise in advance that a lot of the content of today's presentation is very England centric. And I know we're thinking much more broadly than that today, but it's just because that's where I am. But there's lots of parallels across to other programmes of work and other areas. So it was lovely hearing Nanette speak earlier, and I think she touched on a number of things that I'm just going to highlight and emphasize as being really important. So when I think about physical activity, I try and think about it in its broadest sense. So there are so many, as if we think about a typical day in our own lives, there are so many factors that influence whether we will be active or inactive throughout that day. we have as people who can influence physical activity, we have many different strategies, many different approaches to removing barriers and trying to support people, enable people to become more active. So we talk about whole systems approaches, and what we mean when we talk about whole systems approaches is that we need activity embedded into schools. We need to support older people to be active. We need walking programs. We need better cycleways. We need to embed activity in healthcare. We need physical environments that enable activity. We need all of those things, and we need many more things as well. So there's a huge sort of picture when we think about physical activity, and all of those components are interrelated as well. So I just wanted to highlight this from the GAPA plan, so the Global Action Plan for Physical Activity. Nanette mentioned it earlier. They've sort of divided what an active, healthier world might look like. They've divided it into 4 key domains. So we've got creating active societies, creating active systems, creating active environments, and creating active people. And in one of these down here, 3.2 here, we've got incorporating physical activity into health and social services. And so that's really what I'm focusing on today, but I just wanted to highlight that that's a small sub bubble from one of these 4 key domains, and it can never be a complete solution. It's a really, really important, valid consideration, but it can't solve the problem. And no individual approach, program, piece of research, funded initiative can solve this problem. It really does need that broad whole systems approach. So I think that's summarized in my next slide here. So I nicked this off somebody else, but they said, oh, do you want to know what the single most important thing is about increasing physical activity? And I was all ears. And it's, of course, that there is no single most important thing. It's about all of those parts of the jigsaw that we've already touched on. It's about recognizing that they're all valid and important and require approaches to try and reduce barriers and make it easier for people to be active. And I also just wanted to touch upon, when we talk about whole systems approaches, we're talking about complex adaptive systems. So all of the components like healthcare, active travel, primary schools, older people, care homes, social care, that they all sort of interact with one another as well. So we need this sort of mesh of interventions across a system. So I thought I would just touch on physical activity levels pre-COVID in England. So this is Sport England data. Just before we went into lockdown in March, there was an ACTLIFE survey update, and it showed really, really promising results that actually across a number of areas and often across a number of priority groups, the proportion of inactive people was actually less. And so it was a really positive picture, and it was incredibly disappointing that we then went into national lockdown, and that brought all the challenges that it did. So I just wanted to highlight this. This is from the We Are Undefeatables insight pack, and it just highlights the proportion of people who have a health condition. So proportion of people with a limiting disability or long-term health condition along the bottom, and then here we've got people without a disability or without a health condition. It's very broadly split into people who are inactive, so people who fail to meet 30 minutes of moderate to vigorous physical activity over a week-long period. We've got active people who are doing their 150 minutes or more, and then we've got fairly active in the middle. So if we look at the people without a health condition or a disability, then we've got about 20% who are inactive, 21% who are inactive, and we've got a really good proportion of people who are achieving their 150 minutes. If we look at people who do have a health condition, then we're up to nearly 40% of people who are considered inactive. And just to remind you, inactive is failing to meet 30 minutes of moderate intensity physical activity over a week-long period. So it's quite hard to be that inactive. Those levels are really quite low. And yet, if you have a health condition in England, you're twice as likely to be in the inactive category. So that's really, really important. And that's a really massive health inequality. One of the things we know about people with health conditions is that they are likely to have touch points with health and social care systems. We know that healthcare professionals are considered to be credible sources of information around physical activity, trusted sources of information. So you know, there's a very strong argument there for really using that opportunity in healthcare. So again, Nanette touched on some of this information before, but just to really highlight the bizarre situation that we find ourselves in now. So we know that we were in a reasonably good place in terms of the trajectory that we were on with physical activity levels pre-COVID, and then we went into lockdown. The message was very much stay at home. And so it was a bizarre sort of push and pull, because we had this stay at home message, people very fearful about mixing, very fearful about going out, lots of restrictions in place. And yet, on the other hand, as Nanette mentioned earlier, you know, we had the Prime Minister talking about daily exercise on, you know, the daily briefings. So very interesting sort of about people's perceptions of physical activity. And the quote here is from Chris Whitty. He said, "There's no condition, there's no age where exercise is not a good thing. Anything that can be done to encourage and allow people to take exercise is clearly a good thing." So we had these sort of opposing messages of stay home, don't go out, but really try and take your daily exercise. And what we saw through those sorts of opposing messages was that people seem to cherish and really value their daily exercise, their one opportunity to get out and get active and get away from screens every day. So that became sort of institutionalized as part of people's every day. But what we also saw was this huge reduction in incidental activity. And what I mean by incidental activity is, you know, the activity that you accrue throughout the day, from walking to the office, moving from the tube to the train station, walking for a bus, all of that kind of stuff that isn't planned, purposeful activity. We saw big reductions in that incidental activity. So just a couple of graphs and bits of information that I found really interesting. So this is Garmin data. It's global. It's obviously not representative because it's from people who like wearing wearables, wearable technology. So it's not representative, but it does sort of capture a moment, I think. And so we've got average daily steps from Garmin technology wearers. We've got globally in green, and then in the US in the hatched markings. And this is from the beginning of March to the end of March in this year. And what we can see is that there's just a steady decline as we went into lockdown there. And so your average daily steps in April compared with April last year was reduced by about 12%. And this is through March and through April as well. So a huge reduction in average daily steps there from Garmin wearers. And if we accept that they are possibly likely to be more active than the general population, then be interesting to think about what changes we might see in the general population as well. So through the lockdown period, Sport England collected weekly data looking at attitudes and perceptions towards physical activity. As many of you will know, it's incredibly difficult to get accurate data about physical activity levels at population level. So we're always sort of trying to piece different bits of the jigsaw together to understand where we are. But one of the key things that came out from the weekly survey from Sport England was that a large proportion of adults felt it was more important than ever to be active. and that people were really valuing that daily opportunity to exercise. So 70% of adults agreed that exercise was helping them manage their physical health. 61% were using exercise to manage their mental health as well. So there was a real sense of the importance of our well-being, and I think I really felt that, and felt it coming through the the news outlets and papers, that suddenly people were incredibly aware of their own well-being in a way that possibly they hadn't been before. And I think it's really interesting, the data that's coming through around immune responses and exercise, and that U-shaped curve, so that if you are a very low exerciser, you might be more likely to get communicable diseases, and also to have poor outcomes from them. If you're in the middle of the curve, you're likely to do better. But then the extreme exercises as well have impaired immune responses. So we get that sort of typical U-shaped curve there. Some of the stuff that came out early in lockdown that I thought was really interesting was that, in spite of all the barriers and the limitations, people were finding a way to become active. So many people were exercising, but in different ways, to make up for the suppression of normal daily movement. So to make up for the suppression of the incidental activity that we would normally just accrue throughout the day. So going back to Garmin data here, there's so this is global data through March. And we can compare 2019 with 2020. So we've got 2019 in green here, it bobbles along, and this is changes in virtual cycling activity level. So indoor cycling, so think about your turbo trainers, etc. So 2019, it sort of bobbled along there, and in 2020 it shot up through the end of March as we went into lockdown. So people who enjoy cycling and have the kit were turning to their turbo trainers as a means of coping. I don't know if anybody on the call tried to buy a bike in spring this year, but it was pretty much impossible. You couldn't get them for love nor money. So a huge explosion in people finding a way to become active. And then I thought this was really interesting, the graph down here. So we've got February, March, April along the bottom, and this is about floor climbing activity. So and then we've got a number of different countries here, and remember, each of the countries had very different restrictions in terms of lockdown, and in some countries you weren't able to even go outside to exercise. So floor climbing activity isn't about just sort of normal stair climbing, it's about purposefully going out, if you live in an apartment, and running up and down the stairs as many times as you can, as a purposeful, planned activity and way to get your physical activity in. So for people in Italy, for example, who weren't allowed out to exercise, and many people who live in apartments, this became a really viable way to be active. And you can see that stair climbing in February wasn't really a thing, because it isn't really a thing, is it? But then as other restrictions were imposed and our options were pared down, suddenly it became a thing, and people were finding a way to be active by running up and down the stairwells of their apartments. So where are we now in terms of physical activity and COVID? I suppose the honest answer is that we don't really know. It's still early days. There's pieces of the jigsaw emerging, there's survey data coming through. It's very, very difficult to get those population pictures of physical activity, and we're not quite at systematic review stage yet either. So I think we'll get a better picture over the next few months. But one thing that has become really apparent is that for people who were able to, people who had the motivation, the self-efficacy, the means, the equipment, the physical environment, some people were doing more in the early days. But so what the pattern seems to suggest is that the fit were getting fitter, and inactive people were becoming less active. So those health inequalities that have existed for all of time were just compounded by the lockdown situation. So we saw men being more active than women. We saw adults being more active than older adults. We saw people in the most deprived areas being less active than people in more affluent areas. So you could have predicted the inequalities that we'd see in lockdown, and it really has compounded all of those. One other thing that I wanted to just highlight was, as we went into lockdown, I think everybody became incredibly dependent on digital as a solution and as a means of connecting with other people, and a means of getting your shopping delivered, a means of Zooming with your parents or your friends or whoever. It suddenly became a real lifeline. And I just wanted to highlight the impact of people who are digitally excluded. We don't really know what the impact has been on those people because they're incredibly hard to reach and through traditional methods. But I think they're an area of real concern. And for healthcare professionals, I think that's a real point of note, that if you are having routine interactions with people who might not be able to access physical activity opportunities digitally and might be digitally excluded, then how can we support them to stay active? So some of the new insight that's come through from Sport England, again, this is related to the We Are Undefeatables national campaign, which is a national campaign that supports people with health conditions, adults with health conditions, to stay active. They've done a whole load of insight work around how people feel now about COVID and about physical activity. And what it's told us is that COVID is now cited as one of the main barriers to activity for people with health conditions. So that, this is a completely new situation, a completely new barrier. And as we know, it's not going away. We're certainly looking ahead to a very difficult winter as we enter the second wave, and the impact for people with health conditions, older people, people who are digitally excluded. It's how on earth can we could support those people to become more active and to stay active through lockdown periods. And the insight also tells us that many people chose to continue to stay at home even after periods of formal shielding ended. So even after recommendations for sort of formal staying at home ended, people were really fearful and concerned about leaving their home, so sort of opted into an extended period of shielding. So the healthcare opportunity. So we've talked about the whole system for physical activity and how massive and complex and interrelated it is. We've talked about the fact that health and social care is one part of that system, a really important part of it. And we've talked about some of the new challenges that we face as a consequence of COVID and the reduced physical activity levels that we've seen for particular priority groups. So this the green diagram that's on the screen at the moment is nicked from Macmillan, and I think it illustrates really nicely how healthcare professionals, as healthcare professionals, we connect with individuals, we can influence social networks, we can support with physical symptoms, and we can also support and influence people to connect with their physical environment. So there's no doubt in my mind that there's a really strong opportunity for healthcare professionals to influence the physical activity levels of people with healthcare conditions. I just wanted to flag this article that was published a while ago. It's written by a colleague of mine in Sheffield, and they've explored, if we were able to embed physical activity at the heart of the NHS, what would it look like, and the need for a whole systems approach. So the healthcare opportunity is a huge opportunity. It's a very real, valid opportunity, but unless we can connect with other parts of the system, it's going to be self-limited. So we've talked about the opportunity and the scale of the opportunity, the potential scale of the opportunity to influence patients' physical activity levels through connecting with routine touch points and routine healthcare appointments. Again, this is another statistic from Macmillan. It's a bit old now, but despite the fact that we know that physical activity has a key role in preventing cancer, it has a key role in optimizing well-being pre-treatment, in managing side effects of treatment, and also managing the consequences of treatment. At this point in time, and it is 2011, it was estimated that only 6% of healthcare professionals talk about physical activity with their cancer patients. And so there's a massive disconnect between, or a massive mismatch between the opportunity, the evidence around people saying that they will listen to their healthcare professional, and then what was actually happening in practice. And I do think, and I do hope that things have improved since then. So I think that's just a stark reminder of the huge gap. So one of the issues that that often crops up when we talk about embedding physical activity in healthcare is the knowledge gap. And it's often surprising to people who work outside of healthcare that sometimes clinicians don't have the knowledge, the skills, the confidence to talk about physical activity with their patients. And I think this varies professional group to professional group. It varies in, when you trained and what the content of your training was. But it's often surprising that healthcare professions aren't confident to talk to their patients about physical activity. So this is a survey. The slide that's up now, excuse me, is a summary of a survey that we did a few years ago, and we surveyed over 500 physios and just asked them very, very basic questions about did they know the recommendation for moderate to vigorous physical activity, how many minutes per week, did they know the strength guidelines? And what we found was that 60% of respondents knew the moderate to vigorous physical activity guideline, the 150 minutes, but only 32% of people knew the strength guidelines. Nanette mentioned earlier about the the forgotten guidelines, and the fact that the narrative around physical activity has been dominated by the aerobic fitness, the cardiovascular aspect, and the strength and balance aspect has been largely overlooked. And there's a lot of really good work going on at the moment, much of which Tom touched on before we lost him. So I do think there's good work going on to redress that, but only 32% of respondents knew the strength guidelines, and they're not difficult, are they? It's only sort of saying engage in strength training 2 or more times a week. And those findings were replicated by a study of physiotherapists in Australia as well. So there definitely is a knowledge gap. And I just wanted to highlight that there's loads of good resources out there for upskilling healthcare professionals. And so we've got All Our Health, which is a Public Health England, Health Education England resource. They've got free modules and loads of information on there. We've got Moving Medicine, which if you're not already aware of, is really worth a Google and a look around that website. We've got e-learning modules on the e-learning for health platform, and there's opportunities to influence pre-registration curricula, all of which will support healthcare professionals to feel confident, to feel well placed and skilled in having those conversations with people. But having good conversations with patients is a real skill, and it's a real balancing act between recognizing that those, whether it's a 20, 30, 40-minute conversation, or whether it's actually, if you're a GP and it's an 8-minute conversation, that you will have multiple priorities and multiple things to talk about with your patients during that consultation, and that physical activity, the best thing you might be able to squeeze in that 8-minute appointment is there's a leaflet in the waiting room if you pick it up on your way out and have a read, and we can discuss it next time. Or it might be, I'd like to make you an appointment for you to link in with a community support worker or somebody from a local charity or a link worker. So it doesn't always have to be really burdensome when people are talking about physical activity. I think one of the key things is conveying that you as a healthcare professional think that it's really important. And I think, if we're able to do that, even if we're not having lengthy conversations, then then we've gone a long way to supporting people. So I just wanted to flag the nice guidance here on the left of the screen. So this recommended that that for adults in primary care, that inactive adults are identified, that they're given brief advice, and that systems are put in place to support that, including information and training. And this is based on a big review of brief advice and brief interventions in healthcare that showed that they were impactful, at least in the short term, in terms of influencing patient behaviour. Also just wanted to flag here, you'll find this on the Moving Medicine website. It's a short course called Active Conversations. I've not been through the course, but I've heard really good things about it. And so if you feel that you or your people in your department would benefit from sort of training, upskilling around how to have a good conversation with somebody that's underpinned by motivational interviewing approaches, then that's a good place to start. And in fact, before I go on to that slide, I also wanted to just spend a couple of minutes talking about the Physical Activity Clinical Champions Programme. So this is a Public Health England funded programme that's available free of charge for any health and social care professional in England, and it's basically, we have a network of about 50 clinical champions across the country. Those clinical champions excuse me, are trained up to deliver physical activity training, and we'll work with clinical teams to deliver virtually at the moment physical activity training that is evidence-based, and it's a tried and tested model, and to date about over 25,000 healthcare professionals have received that training. The phase 1 delivery was evaluated, and there were some really positive outcomes there, and evaluation of the phase 2 delivery is currently underway. So whether you are tapping into a sort of a national programme of support, or whether you're doing some self-directed CPD around brief advice, brief interventions, having good conversations with patients about physical activity, there's plenty of support out there. Excuse me while I have a swig of water. Okay, so next I wanted to move on from thinking about the conversation, because having good conversations with patients is a really important part of embedding physical activity into clinical pathways, but it's not the be all and end all. And I think, you know, without wanting to labour it too much, if you take one thing away from today, it's that there is no silver bullet. So we need to really look at every opportunity and how we can really milk every opportunity to make it easier for people to be more active. So when I talk about embedding physical activity into clinical pathways, often we sort of talk about specific clinical conditions and how physical activity can be embedded in that pathway as a key treatment opportunity or a key treatment option. So examples for that might be things around pulmonary rehab, or it might be various cancer pathways. And I just wanted to highlight the work that's going on across Manchester, where everybody who receives a cancer diagnosis will have the opportunity to have a supported physical activity, nutrition and psychological therapy programme as a standard part of their treatment. And whilst this has happened in isolated sort of pilots before, this is being done at scale across the whole of Greater Manchester. It's been absolutely woven into the systems at scale, and it's a really interesting programme of work to look at. So sometimes when we talk about embedding physical activity into a clinical pathway, we talk about dropping a package of physical activity as a treatment option into a pathway. What I'd like to encourage you to do is to think really broadly and think about a sort of process map of the journey that a patient might walk as they interface with health systems. And you know, that might be sort of right from booking appointments online, to having conversations with secretaries, to sitting in waiting rooms, to driving around looking for somewhere to park, to entering the hospital for the first time, all of those things. It will include the conversations they have with healthcare professionals. It will include treatment options. But when we look at it from that sort of broad, zoomed out perspective, then hopefully you can see that there are many opportunities to embed physical activity in clinical pathways and to influence that journey that patients take. And some of the, to give you a couple of ideas, some of the ways that we can influence that pathway are, when people get a clinic letter, they could have a couple of sentences in the clinic letter about, whilst you're waiting for your appointment, it's really important that you stay active. It's very likely to be good for you. If you follow these basic rules, it's very unlikely to do you any harm. We look forward to talking more about your physical activity levels at our next appointment. And just if that comes from somebody who's perceived as being very influential within a healthcare team as well, if it comes from a consultant, and that can carry an awful lot of weight in terms of setting a patient's expectations or a person's expectations about what they might experience when they come to an appointment. I think we can also influence our physical environments as well. So what information have you got in your waiting room? Can people stand up rather than sit? How can we encourage people to hopefully avoid the perils of trying to park at a hospital and to sort of park further away and walk in? And is that something we could put in letters? How can you showcase the fact that you've got a load of bike racks so that people can either cycle to work or walk to work, or walk to appointments rather than driving? So there's so many different ways that you can embed physical activity into a clinical pathway, and it's not always just the obvious sort of exercise as medicine, although that's a really important part of it. So I mentioned earlier that I'm just checking time. I mentioned earlier that healthcare, the healthcare opportunity is only as great as our ability to link with other parts of the system. So we can do a brilliant job of embedding physical activity in healthcare, but if we've got no connections with other parts of the system, then we're limited before we even start. So I just wanted to flag here that the social prescribing agenda and the commitment across England to link workers in all primary care networks is a really positive move. I think it reduces the time burden on healthcare professionals and that expectation that they might know exactly what's going on locally. And it might be, I think it's a great opportunity for us, rather than sort of carrying the burden of having all that information as it constantly changes, that we can refer on to a link worker whose job it is to sort of keep tabs on all that local information. So I just wanted to flag that quickly. I think really important agenda for us to engage with and influence as it develops. And then final slide, penultimate slide from me. I just wanted to flag the Active Hospitals work that's part of the Moving Healthcare Professionals programme that's Public Health England led. So there was an Active Hospitals pilot at Oxford. This has been written up as a case study, and you'll be able to find that. They have developed an Active Hospitals toolkit. So if you work in secondary care, and if you're wondering how on earth you can influence the system around you, then there's some really great information on Active Hospitals. I think historically primary care has always been thought to be more conducive to facilitating physical activity, but I think with the whole hospital-acquired deconditioning agenda, then I think secondary care is every bit as important. So I'd really encourage you to have a look at the Active Hospitals work, and to think about your own work environment as a micro system within the bigger physical activity system as well. So you've got you yourself as a clinician or as a researcher or whatever you do, you've got your work environment, your work team, your physical space, physical environment, and thinking about how that sort of connects into the local physical activity system. The place-based physical activity system is a really interesting thing to do. So final slide there of some of the resources that I've touched on, and I should have mentioned earlier that all of the images in the, or most of the images in the presentation. If you click on them, they'll take you through to the source as well. So I think that's it from me. I hope I'm vaguely on time. If we've got time for questions, I'm more than happy to try and answer them.
Yes, I think we've time for a couple of questions. If anybody wants to put something in the chat, I think that's really, really useful, Anna. I think we've a lot of work to do. You know, we all know that we are, you know, those of us who are working in clinical practice have an opportunity within the hospital system to actually influence things. However, we don't always think of those incidental or that entire journey. You did talk about the mesh of interventions across all areas, you know, schools, hospital, community care homes. How did you manage that? Because that's particularly difficult for us.
Oh, well, I certainly wouldn't say that we've nailed it, but it's an ambition. You know, it's an ambition, and I think the ambition starts by recognizing the connectivity across the system. So we know that locally in Sheffield we have so much work to do to further develop those networks and those links. But what we do have is we have a shared ambition, and we have high level support from all of those organisations. So from the local trust, the CCG, the universities, the schools network are all brought into a shared vision for what a physically active Sheffield could look like. So I think we have the high level shared ambition, but we still know that we have a lot of work to do into actually translating that into meaningful structural changes across the city that make it easier for people to be active.
Yeah, there's one comment here from I think it's Grania O'Donoghue. She talks about that they don't have the same healthcare and community links as you have in the UK, and would like some advice regarding a micro approach, for example, step 1 to embedding physical activity in the HSE and working around that initially. And I think that's probably something that we all need. You did allude to it, and certainly here we can maybe look at, while we're doing pockets individually, we can look at embedding that education among staff across the region.
Yeah, absolutely. So I think in terms of first steps, we've got some great examples of physio departments who have just been real self-starters with this and have looked at the assets that they've got access to, have trained up the members of their immediate team using resources that are freely available. They've made connections with local physical activity delivery operations, and they've also joined in with national campaigns as well. So I think I appreciate when you're sort of thinking about the whole systems approach, it's enormous and it can feel completely overwhelming. But I think, you know, starting small, looking at your immediate team, your immediate workspace, thinking about workplace initiatives as well. So actually, how can you get your immediate team on board with promoting physical activity, and you know, that's for themselves as well in terms of a sort of workforce physical activity initiative. So how can you support your team to be active, and how can they support the patient population to be active? And I do think there's small sort of easy steps around active conversations, training, and looking at the freely available information that's out there.
Okay, thank you very much. That's been really useful, Anna. If anybody else has any questions, if you want to put it in the chat, I'm sure Anna will be happy to have a look at it and answer them while we get through the rest of the day.
We're almost at the end of our program, but for those who've been with us all day, and I think that's the majority, you know that we had 3 presentations from the colleagues in the University of Erlangen on the ACTLIFE project, and we played 2 of them for you earlier. So now I'm delighted to introduce the final presentation. And this is, again, similar to the Italian presentation. It's looking at the effect of COVID and the RCT that had to be stopped, and looking at that effect of what was essentially detraining on the group. And it is presented to us today by a colleague from Erlangen, Wolfgang Kemmler.
Dear colleagues and guests, First of all, let me introduce myself. My name is Wolfgang Kemmler. Excuse me. My name is Wolfgang Kemmler. I'm the head of research of the Institute of Medical Physics, University Erlangen-Nuremberg, and I would like to present you our data on corona-induced effects on bone mineral density and body composition in the ACTLIFE cohort, a 3-month detraining follow-up. What's the rationale and the background for our project? The 18-month ACTLIFE intervention has to be stopped in March 2020, immediately after the 13 months assessment due to the COVID-19 pandemic. After 4 weeks of training breaks, we decided to focus on the detraining effects and terminate the ACTLIFE intervention. While all exercise facilities in Bavaria, Germany were closed for 3 months, individual outdoor activity, physical activity and exercise was still allowed and possible. Correspondingly, participants of both groups increased their individual outdoor aerobic activity by about 30%. However, they were unable to conduct any resistance training exercise apart from the home exercise training, about once weekly, 15 minutes of slide resistance exercise training. However, with respect to confounders during the training period, no relevant changes of dietary intake, pharmacologic therapy, or other variables that might have confounded our results were observed. Thus, we focus our results exclusively on the detraining period. I would like to present the data on bone mineral density at the lumbar spine and lean body mass. The round circles, indicate the exercise group, and the triangles indicate the control group. Y-axis displays BMD changes, and the x-axis indicate the development of training and detraining period. During the intervention, BMD at lumbar spine non-significantly increased in the exercise group and significantly decreased in the control group, resulting in significant exercise effects. That means significant differences between the exercise and the control group in favor of the exercise group. This effect, however, get lost after 3 months of detraining. In parallel, lean body mass significantly increased in the exercise group and significantly decreased in the control group. Exercise effects were highly significant after 30 months of exercise. However, decreases due to detraining were significantly higher in the exercise compared to the control group. Nevertheless, in contrast to bone mineral density, after 3 months of detraining, a significant excess effect remained. Total and abdominal body fat mass or rate were comparable. Thus, I would like to focus on total fat mass changes. During intervention, total and abdominal body fat maintained in the control group and significantly decreased in the exercise group. Correspondingly, exercise effects were significant at intervention end. Other detraining effects were significantly more pronounced in the exercise group compared to the control group. After 3 months of detraining, we observed still a significant effect for total, however, not for abdominal fat. Finally, I would like to present the results on muscle strength and power. During the exercise period, leg extensor strength and power significantly increased in the exercise group and maintained in the control group. Briefly, training changes were significantly higher in the exercise group compared to the control group. However, after deep training, we still observed a significant exercise effect for leg extension strength. However, not for leg extension power as determined by a jumping test. Our conclusion is clearly use it or lose it. 3 months of absence from a supervised exercise training, HIIT exercise, high intensity exercise protocol, resulting in deep training effects that were significant for lean body mass, muscle strength, and muscle power. However, there's some evidence that stability of adaptation increases with the duration over which training is performed. Further, continuous rather than the present intermittent exercise program for prevention therapy should be implemented by commercial and public healthcare providers. Thank you for your attention. Dankeschön. Grazie mille.
Dankeschön, Wolfgang. That was a recorded presentation and the final presentation from ACTLIFE, and it also brings us to the end of the day. It's been a long day, but I think most who have joined have stayed, and hopefully therefore that's a sign that you've enjoyed it and gotten something out of it. From me, just to let you know that all the presentations will be uploaded to YouTube early next week. All attendees will be sent a link to the presentations and the slides that accompanied each presenter's talk. So if you could give us till early next week, that will be sent to you. All that remains for me then is to thank my colleagues Lou, Deirdre, Kelly and Julie, the physios from the Belfast Trust, for allowing us to collaborate with them on this study day. My ACTLIFE partners in Bologna and Erlangen, that's Laura and Giuseppe, Michelle, Simon and Wolfgang. And finally, my colleagues at Ulster University, without whom the whole technical element of today would not have been possible, and that's Angela Carlin and Kyle Ferguson. So can I thank you all, wish you a good day. We're just before the 3-minute mark, so stay safe, stay well and stay active, folks. Take care. Bye-bye.